gave Dr. Newsom mine. Absolutely. Newsom, you ready to go then? You want to call it to order? We can get started.
Yes, this is Lenora Newsom, and we're having an informal pharmacy board meeting today, and we're at the board offices, and the time is 9:07. Board members present, Dr. Rodney Richmond, Dr. Brian Jolly, Dr. Clint Boone, our executive director, Dr. John Kirtley, our assistant director, Dr. Brenda McCravey, and Ms. Ashley Vales is our attorney. Our first person up is, I'm gonna turn it over to Dr. Kirtley, our first person up today.
Absolutely. How do you pronounce your first name?
Smitaben.
Smitaben?
Yeah.
Okay, and Parmar?
Parmar is the last name.
Okay. Dr. Parmar, I'm John Kirtley. I'm the director of the Board of Pharmacy. I'm going to tell you just a couple things about who you're speaking with this morning and a couple things about the procedure today.
Yeah.
Realizing you've never sat in that seat and it may be a little bit different than what you've seen before.
Yeah.
We call this our informal committee because it is largely a conversation back and forth across the table versus a formal hearing where we swear everybody in and take testimony much more officially, kind of like going to court. On this side of the table, we are all staff members here at the board that work in the office each day. And on the other side of the table, these are 4 of our pharmacy board members that are decision makers here today. The board members are just seeing a copy of your application on our little tablets here. And in your application, you let us know that there had been some history on your application. In just a moment, I'll let our staff give a brief overview of what that is, and then the board members will want to talk to you about your application.
Sure.
And in that, at the end of the conversation, the board members are going to come up with some suggested action. It could be to approve your application, and that way you'd be able to take our law exam. It could be to deny it, to postpone action on it. We don't know until they actually tell us. Whatever they come up with today, you can either agree or disagree with. The most important part of that is if you agree with it, we go forth with what they've asked us to do. If you disagree, since you're an applicant, it kind of gives you a choice of forget this and walk away from it, or to say that you want a full hearing before the full board at a later date, which would be an official formal hearing. That'd be all 8 members with the court reporter, hearing officer, and all that entails. So I always ask 2 questions. First of all, do you know why you're here today?
Yes.
Do you have any questions about how this process works?
Not really.
Okay. And once again, realizing you've never sat in front of us before, if you have a question or need some clarification on anything during this, by all means, get our attention, ask us any questions you have, and we're going to do our best to help answer that.
Perfect.
All right. Turn it over to staff.
Dr. Parmar is here on a reciprocity application. She did disclose in her application that she had been the subject of disciplinary action. Her license had been out of the state of Florida. And I'll let her explain it as well in more detail, but she was the manager and the pharmacist held responsible when there were some issues with inspections of the pharmacy. There were some numerous violations. A couple of them were the medications not properly labeled, expired medications found in active stock, licenses weren't visible to the public, and counseling was not offered to patients picking up their prescriptions. The Florida license was placed on probation for 2 years. She was ordered to pay a fine and investigation costs and complete some CE. And her license in Florida is now active, so she's completed all of those requirements and is seeking reciprocity, I believe, for a job opportunity.
That's correct.
Okay, so you're thinking about moving to Arkansas or just
No,
get out of
not
state?
really. I'm gonna be in my state, but there are a lot of pharmacies out there. When I go for interview, they are always looking for somebody who has a multiple state license. And I recently got a job that I started, and they are also in a multi-state, and they yet don't have a Arkansas license, but they are in future looking for it. So it's definitely a plus point if I have a license.
So the issues that happened with Florida, when did those happen?
That was back in 2012.
2012?
Yeah.
You put on your application that you're also licensed in 4 other states. Are those still active?
I'm sorry?
Put on your application that you're licensed in 4 other states as well? Virginia, Tennessee, Oklahoma, and West Virginia. Are those still active?
Yeah, they're all selected.
Did you obtain those after the 2012 issue or?
Yeah, those are all applied this year only.
Okay.
Yeah.
And you haven't had any other problems?
No.
Okay, all right.
Well, it says that the last day that you worked was September the 8th of last year. You've not worked in the last 6 months?
No, so I recently in February joined the pharmacy.
I'm sorry, what was that?
I recently joined the pharmacy in February. So from September to February, I was still looking for good opportunities. Because I worked all whole time in retail pharmacy and I was trying to go into more like infusion pharmacy or compounding pharmacy to gain more experience.
So you just voluntarily took 5 months off?
Pretty much, yes.
What does pretty much mean?
Because I was not like, I didn't want to sit at home, but at the same time, I was looking for a good opportunity. So I don't want to go back in a retail. So I was, at one point, I was also looking to open up my own and I was looking all the opportunity and then I'm still looking for it. So meanwhile, I decided to take up a job.
But at the time you filled out the application in January, you weren't working. That's why you marked.
That's correct.
What type of facility are you working in now?
Right now, it's called retail / compounding pharmacy,
Sterile, non-sterile?
non-sterile.
Non-sterile. Examples of products, can you tell me what kind of products you guys compound?
They do a lot of cream, ointment, troches, and stuff like that. I recently joined, so I'm still in just the verification process. I don't handle the compounding part, but yes, they do a lot of compounding for skin treatments and stuff like that.
And that's something new for you, you haven't compounded before?
I have a little bit of experience, not whole extensive, because in a retail pharmacy, we used to do a very basic compounding. So yeah, I'm still learning.
And would you want to be the PIC for this pharmacy or another one?
Until I completely learn it, I do not want to be PIC because I do want to learn what I'm doing.
Yeah, that was my concern, is if
Yeah.
you're just moving into this, whether we'd really want you as the PIC.
No, not right away, because I do want to learn more first. And that's why this is a good opportunity because they don't have the license. So even when they decide to apply by that time, I should have experience.
Does any other board members have any questions of this candidate? What is the will of the board?
Make a motion to approve.
Second.
Okay, I have a motion and a second. Any further discussion? If not, all those in favor of the motion signify by saying, did you have something else?
I just wanted to let you know, Nancy said if she's ready to take the law exam, if she's approved, she could take it today if she's ready for that.
Okay. So you just want to approve that she's eligible pending?
Yeah, pending successful passing of our law exam.
Okay, we'll
Make
make
a
that
motion to
amendment.
approve.
All right, thank you, sir.
I'll second the amendment.
Thank you. Okay, all in favor of this motion, signal of saying aye.
Aye.
Any nays? The motion passes. So you need to take your exam, but you're prepared to do that today?
Yes,
Okay,
I
great.
come prepared.
Okay, great.
Did you get to see the law review?
Yeah, I saw the video.
The most boring hour of your life this year.
It was very helpful to me because sometimes you read stuff that even when you're reading, you know that this is not what you're gonna be using in typical life
Yeah.
situation. So in the video, it's very
If nothing else, we try to say, here's a whole bunch of stuff you don't even need to worry about versus here's stuff you do need to worry about to help
It
you
was
focus.
definitely helpful. I watched the video.
All right. Any questions before you take the test about the test?
I just didn't know what's the time limit or how much.
We usually give like 90 minutes.
90 minutes,
It's
okay.
still multiple choice, 76 questions. We'll get you, we've got a room right back here that we can sit you down in. It'll be nice and quiet. We'll try to keep the rowdiness down out here so we don't disturb you. Yesterday, there was a meeting next door and we don't know which stand-up comedian they had, but for about 30 minutes, apparently it was a really funny meeting. So they were having fun.
Yeah, besides that, yeah, I think I'm good to go.
Okay. All right. I think that's all we've got.
Thank you.
Thank you. So should I just wait outside
Yeah,
or?
we'll get you to Miss Sweet and we'll get you a test started.
Perfect. Thank you.
I think our 9:30 is here. Do y'all want to take just a quick break? You can refresh coffee or anything else and then get started as soon as they're ready?
Oh, good.
Okay, we'll see whenever they're ready. I don't know if they're waiting on anybody else. I've
Okay,
just
all right.
seen them working. On our 9:30. Should be right in front of you. I think we gave you yesterday on your sheets.
Here's some.
Here you go. Oh, there we go. Thank you. That's the cheat meeting.
Here.
Got him on green.
Get back on here.
Spells, you ready? All right. Dr. Hollingsworth, you want to introduce yourself to the board? I'll tell you who all you're talking to today and just a little bit about this procedure. And it's on, when it's on green, it's go.
Okay, I'm Trent Hollingsworth, pharmacist at Westside Pharmacy in Benton at the moment.
Okay. As I think you know, I'm the director of the board. On this side of the table, we are all staff members here at the board. Myself, Dr. Brendan McCready, who's our assistant director, Dr. Kevin Robertson, who is one of our board inspector investigators, and Ms. Ashley Vales, who's our legal counsel. On the other side of the table, we've got 4 of our pharmacy board members with us today that are kind of decision makers on any decisions before the board. We've got Dr. Clint Boone, Dr. Brian Jolly, who's current president of the board, Dr. Rodney Richmond, and Dr. Lenore Newsom. Dr. Newsom is the chair of our informal committee whenever we have these procedures. So in this instance, the way that we usually do this is you've got kind of an order notice of hearing. And when we try to do these as informal, we say it's very similar to something like mediation. We're trying to have a conversation back and forth across the table, discuss whatever has happened, and then at some point, the board members are going to have some suggestion for action. Yours might be a little bit interesting because we have you who were the pharmacist in this specific instance, and then the next thing that we have to visit with is the pharmacy. I have seen, I'm just forewarning you that sometimes they've said, well, we've talked to the pharmacist. Now we want to talk to the pharmacy before we make a decision on what goes where or how we put the pieces of the puzzle together. But in many ways, it's oftentimes helpful that you kind of have your time and they have kind of their time.
Okay.
Most important thing for you is when we have this discussion, whatever action that they come up with as a suggestion, you can either agree or disagree with it. Since this is kind of like mediation or, a consented agreement of types, if you agree with it, we go forth with whatever they say. You don't have to agree to it right here today, sitting here listening to it either. Whatever they ask us to do, we will generally reduce to writing and send to you. That way, if you have any questions about what's in that document, we can work through that before you determine if it's something you would agree to or not. If you disagree with it, it's your chance to say, basically to request to appeal this decision and have a hearing with the full board at a later date. The full board is all 8 members of the board, a hearing officer, a court reporter. We swear everybody in, and it's just a more formal procedure for us overall, instead of this being more conversational. 2 things I always ask everybody is, do you know why you're here today?
Yes.
Do you have any questions about how this works?
From this point forward, no.
Okay. And I say that because at any point during this, if there's something that you're not clear on, if there's something you want some clarification on, or if you need to ask a question of us, by all means, get our attention, ask any questions that you have. We realize that you've never sat in that chair and we do this all the time. So what seems normal to us is something brand new for you. With that, I'm going to turn it over to staff to, kick off our side of it. And then I know here in a little bit, the board members are going to want to ask you some questions.
Okay.
You have on your packet an order of notice of hearing that's been served on Dr. Hollingsworth. Those are the allegations that we'll be discussing. Obviously, at the informal, we're not going to ask you to make findings on those. But each of those allegations represent deficiencies that were found several times during inspections by Dr. Robertson and Dr. Fain. Also in your packet, we have a spreadsheet that sort of summarizes the findings that were issues in the inspections that Dr. Robertson will sort of summarize for you. And we have exhibits in there that go along with the spreadsheet that sort of reference the various issues and the facts that supported the findings in the inspections. So I'll let Dr. Robertson sort of spell that out for everyone.
Okay, so this is related to some inspections that occurred since 2017 at Smith Caldwell, and specifically for their sterile compounding aspect that they were doing. The compounding that was occurring at Smith Caldwell could be classified as high risk. Now it's considered what they call category 3. So it's making things from non-sterile powders to purport to be sterile and potent from non-sterile powders. So that's what I'll kind of go through. What I would do is I'll go through, I'm just going to jump around on some of this from the spreadsheet. So what I would do if I were you, if you wanted to look at the documents, I'll refer you to just the appendix that I'll be referring to, because I'm trying not to cover everything because there's a lot of material here and I'd rather not just kind of drag it out for a while. But if you've got questions, please stop me at any time. There were, again, as Ashley said, there was an inspection that occurred in 2023 by Dr. Fain before she had left. And that was, I believe it was completed in July of 2023. And I had conducted one in 2022. So there's some repeat observations that occur. The first one that I'll go into is extending beyond use dates without further testing and justification of those extensions of beyond use dates. There were several master formulations that had notations of verbal advice from quote, Don consultant at PCCCA, unquote, but he didn't have supporting written documentation for that from PCCA. One example is cyclosporin, where one product, capric triglyceride, was replaced castor oil, which is what the study that was used that supported it. The second one was a triple mix, and this is Appendix A if you want to see the particular documents. The triple mix penile injection regular master formulation stated, quote, December the 8th, 2021, from Don Consulting with PCCA mixing our own bacteriostatic sterile water. It will not void the PCCA bracketed study and our Eagle testing method suitability. And that's not correct. Anytime you make any kind of substitution on a study, especially when the study states anything variation from that negates the study, then it negates the study. The response was that cyclosporin 2% would be discontinued on August the 1st, and that further documentation will be acquired in the future if allowed to compound. Further, the master formulation was lacking supporting literature. This particular one from the one related to the progesterone, the cyclosporin 2% from the 2020 inspection. And it was on page 23 of that inspection, but that's, I wouldn't, I mean, it's that one, if you go into it's in your packet, but there's a lot of content in that area. So the next one I'll go into is testosterone cypronate, 50 milligram estradiol, 2 milligram per mil. It was an oral study allowed for a frozen BUD of no more than 45 days. And stated that extension of BD beyond must be supported by other testing, including method suitability. Documents provided only indicated sterility testing. Furthermore, the master formulation stated the use of PCCA branded chlorobutanol anhydrous in the compounding log from this particular one it's in Appendix F was substituted with Spectrum. The response was that product would be discontinued on June the 21st, and further, there was no stability indicating evaluation for that substitution. And the method suitability documentation only states, quote, direct inoculum. It doesn't really reference USP 61, 62, or 1227. The next thing is extended BUD bracketed study for a triple mix stated only PCCA chemicals are to be used in the master formulation listed PCCA brand, but compounding log for this particular product was using Darmerica brand phentolamine, and that's Appendix G and E. If I move too quick or talk too quick, sometimes I have a tendency to talk too quick. Please tell me to slow down and give you time to look if you so wish. The next item are the formulas and instructions for mixing and diluting the cleaning and sanitizing agents prior to use, and its preparation of cleaning supplies documented. And the products that were being used for really decontamination, because bleach is not a cleaner, it doesn't have any surfactants in it. It was a bleach of 1 to 10 ratio mixture. There was no documentation of its preparation and no labeling and beyond use dates assigned. Further, without documentation of mixing, you're unable to determine if the adequate bleach mixture was made. For example, when you buy bleach off the shelf, it can vary in its concentration just on its base. From hypochlorite, it can vary from 1.25% to 5%. And that affects the mixing ratio. It could be 2 to 3, it could be 1 to 9. And if you look at USP 1072, it states that the pH alters its effectiveness, and sometimes it requires the addition of a weak acid like vinegar or something to make it more effective. The next item are appropriate cleaning agents used that are effective for bacteria, fungus, and spores. This was a repeat observation from 2017 and 2020. Record indicated cleaning alternating between sterile IPA, which is isopropyl alcohol, on one day, and using Pharma-D on the opposite day. And sterile isopropyl alcohol is not an EPA registered germicidal detergent, and you must clean before you do any disinfection.
Dr. Robertson,
Yes, sir.
you said on the bleach, there's variability. Did you say the pH or the concentration?
The concentration that you buy, if you were to go to a store and buy bleach off the shelf, the concentration can vary from the manufacturer. It can vary from 1.25% to 5 usually.
So how do you know what you got? Do you have to test it to see what the concentration
They
is?
say it on the label.
They say it on the label?
It may say it on the label.
Okay. Thanks.
So the response for the alternating between isopropyl alcohol and the Pharma-D It was inadequate because it didn't really address when the revisions, this inspection occurred in July. And the response was submitted in August. In November, only a few months away, the new version of USP 797 kicked in. Well, with category 3, it got much more rigid. It got much more rigid to the fact where in the past you could use a monthly sporicital and then went to a weekly. And it wasn't addressed in that response. And it also required that anything that was used in an ISO 5 classified area, which was inside hood, anything that goes in there, the cleaning agents, the cleaning supplies, all that have to be sterile. And that wasn't addressed in the response. And it also has to be an EPA registered one-step germicidal cleaning and disinfectant. And when you dig through the documents, and again, it's Appendix H, there were missing entries throughout the documentation, but it didn't state why. There would be days that were missed for cleaning if it was not compounding or if it was weekends or holidays or so forth, but there was missing dates for documentation of cleaning. The next item, does daily cleaning and sanitizing include counters and easily cleanable work surfaces and properly documented? So this is a repeat observation from 2020 in that the cleaning logs are very vague. It wouldn't specify really what there was it was a large area. There were 4 rooms with 2 CVEs, 1 VCB, and 2 biological safety cabinets, and some of those were for hazardous drug compounding. And so how you clean and disinfect and deactivate it with hazardous is different, and it wasn't spelled out in that documentation. And that's Appendix H. So the next couple of items are going to relate to training. And so this is Appendix I. Yes, sir.
Any issues related to autologous serum drops, or are you planning to get to that later?
Yeah, we're planning. Yeah, there's some issues with autologous tears, yes. Repeat observation from, this is, again, this is related to training, repeat observation from 2017 and 2020. It was a single page. It was just a single page that covered everything from garbing, cleaning, aseptic technique, and so forth. And with the level of complexity that we're talking about with category 3, now classified as category 3, that was inadequate. And the use of equipment and proper cleaning of those agents, absorbing first air and all that stuff wasn't spelled out. So to the degree of what's required for that kind of complexity of compounding wasn't specified. Again, and still in Appendix I, the biannual glove fingertip testing was performed. However, the lot number and expiration dates of the glove fingertip media plates are not documented. They were only taking pictures, and there was no documentation if they were pass or fail. And then on the directions for doing the touch plates in step 4 and 5, it instructed that you must sterilize your glove before you do your glove fingertip test. That's something I saw at first when I was starting to do inspection, and it tapered off. People quickly learned you're not supposed to. You're supposed to. The whole point of that glove fingertip test is, can you don sterile gloves without contaminating them? If you put alcohol on your hands, that kind of negates the whole point of the test. And there was lack of documentation of storage temperatures and time frames of the glove fingertip plates for the 2 pharmacists in June of 2022. The response was inadequate because must be a minimum documentation of starting. This is with the new standard. Again, because the new standard was going to be kicking in November, that you at least have to document the temperature of your incubation, at least on the first date. And that wasn't incorporated into the revised or submitted documents. And it was inadequate because it stated, quote, recently updated to clarify when sterile IPA is sprayed on hands and when it's not specifically, as it specifically relates to glove fingertip test. And again, this was something that haven't seen in a while of that being a finding. It was inadequate because it didn't address the November the 1st required revisions that every 3 months you have to do. And that's, again, the standard for category 3 made things significantly more complicated. And so media fill and glove fingertip tests have to be done every 3 months for category 3 compounding. The next thing was media fill testing. Again, for high risk compounding, the media fill testing was done. The pass fail again wasn't documented. It was only pictures of vials, and some of those weren't visible that you could see if there was any kind of contamination. And because they were using in the media fill the filtration process and the bubble point test, the bubble point was not documented. The response was inadequate because the incubation of the media fill is different from what it is from glove fingertip and surface samples and so forth. The response was that it was going to be corrected to 30 to 35 for 48 hours and then 20 to 25 for 5 days. But it's really supposed to be 7 days for each. So that was a issue there. The next issue, this is Appendix J. Does compounding records include the name, lot numbers, and expiration dates of all components? The progesterone master formulation doesn't match the compounding log. The master formulation didn't list polyoxyl 40 hydrogenated castor oil, but the compounding log showed use of a 2-gram polyoxyl 40 hydrogenated castor oil. There was some issues with now prostadil lot that a filter was substituted and there was no justification or proof that that filter was appropriate for that. There was another alprostadil lot that Dr. Fain observed that the BUD of the stock solution alprostadil was not provided because when you make a batch, whatever the shortest beyond use date of any of those components is what's supposed to dictate what your end beyond use date is. There was a formula for MIC, and this is Appendix J, states that the stability BUD study of number 10834 that only PCCA chemicals are allowed, but again, LETCO chemicals were also substituted with the extension of a beyond use date. The next finding, does compounding record include total quantities and number of unit compound? This was a repeat observation from 2020. And this is related to the autologous tiers. The autologous tiers formula was inconsistent with quantity and within the document. The master formula and the compounding log are on the same page. The document is not clear when a lot number is doubled or modified. The response was that they didn't really understand why this was a repeat observation. And the reason it was a repeat observation, and there's some more examples of this if we go on, the level of detail that has to happen with this kind of compounding, because I have to review all the inspection reports and other documents from folks that want to ship into the state that do from raw powders. And the level of documentation that has to be done, there's a lot of detail, and the detail and the quality control and that type of thing weren't there. And I think that's what she was getting at when she made that statement of it was a repeat finding. For example, if you look at Appendix K, at the top, it states that there's 12 and 48 milliliters that's used. But then when you look in the body of that document, it uses a totally different volume. It's 13 and 65. And then when the revisions were submitted in the master formulation that was submitted back for response, that wasn't corrected. It was just modified somewhat. So it said 6.5 at the top and 25.5, but in the body it said 67 to 30 to 35. So
this may be beyond the scope of what you would expect, but do you know, like, were they getting HIV, hepatitis screening results as a result?
I have no idea about that.
Where were they compounding the serum eye drops?
They were getting, from my understanding, I could turn this, that would be Dr. Hollingsworth. A question for him would be the tiers were centrifuged down at Slay Memorial or Magnolia, and then they were transported to the Smith Caldwell.
Wait and ask Dr. Hollingsworth.
So on the next item was again some observations noted in 2020. Does compounding record include person performing the quality control issue? And again, it's quality control. There's some examples throughout Appendix L where there's several that the person who prescribed it was not the person listed on the label. And there was one particular prescription where it was a request to refill authorization that was faxed to somebody and it was control, and you can't submit a control substance for a refill request. The next item is Appendix N. Does the compounding record include sterilization method? There was no documentation of the time and temperature supplied on compounding the log from that progesterone, and it was inadequate because it didn't provide evidence of use of a biological indicator in the autoclave. Next item, another repeat finding from 2020. It was Appendix M and N. Bubble point testing performed on most compounding logs and the results documented, but there is no documentation of an expected bubble point is not on the master formulation of the compounding log. The progesterone master formulation called for bubble point testing and no results or filter information was provided on the compounding log. If its bubble point testing is required to be performed, or if it's not required to be performed, it shouldn't really be on the master formulation. So it's another example of quality analysis. The next item is sterility testing, USP 71. This is Appendix O. The pharmacy was performing in-house sterility testing for 20% serum tears until May the 16th of 2023. And they were utilizing QT micro testers. And just from my exposure and training that from all the training that I've been through, the only places that I've seen to do in-house testing is maybe a 503B where they have their own microbiologist on staff. And so it's not usually done and recommended to be done in a pharmacy. Dr. Fain noticed that the QT microtester had no documented method suitability for 20% serum tests, but she did find documentation, I believe, on the website that stated 100% serum tears, quote, fail, would not filter. She requested information regarding that method suitability for sterility testing of autologous tears from the pharmacy on 5/16 and was told on that time that the pharmacy no longer performed in-house testing. So it was in-house testing up to that point, and then they stopped. Also, the container closure integrity test for serum tears didn't contain serum, but only saline for injection. The response was inadequate because it stated there was no plan of corrective action submitted and stated belief that the understanding of a container closure test was just to evaluate a container and the contents didn't impact the outcome at all. Also observed that if you look at the in-house sterility testing results, that it was unable sometimes to determine what the incubation temperatures actually were and the duration of those documents. The next item is Appendix M. It's a repeat observation from 2020. This was because when you're making high-risk things, how long before items are sterilized dictates what happens downstream with those items. You have to document when you started compounding and when you ended, and that wasn't done. Only the ending time was documented. And the item Appendix P, there were revisions to SOPs and master formulations didn't indicate versions or revision history. There were things written in the margins, and you can see from Appendix P, things written in the margins, conflicting information, and directions that were not clear on those SOPs and master formulation. Some of the SOPs would state things that were incorrect, like you're supposed to use a scrub brush for when you're doing hand hygiene, and that wasn't occurring, and that's not something that's done. And then it would reference tacky mats being used, and they weren't. And then indicating that gallons were reused, but they weren't being reused for hazardous compounding, which you're not supposed to do. And it would reference barrier isolators, and there was no barrier isolators in the facility. And it didn't discuss changing gloves every 30 minutes. And there were some things in there, I would say, that when you're dealing with this level of compounding and complexity that can impact patients, that document your SOPs and your master formulation should be fairly professional. There were statements, like referencing movie characters in SOPs, I don't think is appropriate to reference in an SOP. And so, again, concerning material. So if anybody has any questions.
I've got a couple. You've talked about all your findings and Dr. Fain's findings. Can you go over your interactions with Dr. Hollingsworth when you did your inspections?
I would say there was so I've been doing this since 2017, and I would go in and I wanted to help people get up to speed on things. And sometimes I've learned some people only hear what they want to hear, and they hear parts of things. And I believe it sometimes that Dr. Hollingsworth was trying to use this as a consultant, and we actually had to have our legal counsel send a letter stating that we can't be a consultant.
Does staff have a recommendation with regard to Dr. Hollingsworth?
The staff would recommend that Dr. Hollingsworth not be allowed to make sterile compounds.
And that's based on your repeated violations that you and Dr. Fain have seen over the years with regard to his sterile compounding. Is that correct?
Correct.
That's all the questions I have.
Okay. Go ahead. Did you have a comment, Dr. Boone?
Were there any sterility issues, anything that came back positive, had sterility issues in any of the products?
There was no findings. What she did on her last inspection was that she sent out a request for a list of certain things that were high frequency products, and then she would ask for a sampling of those. And one key thing about sterility testing, it's all odds. So that's why you build a system. That's why they always say you build a system. That ensures as sterile as it can be. And so in other words, what I'm getting at is a sterility test that comes back positive. It's nice, but it doesn't prove absolutes. So, but to answer your question, there was no documentation that I observed from her report or any of the material that I've seen before that showed that there was a failure that I remember from my inspections.
Thank you.
Did anyone else have any comments, board members? Okay, Dr. Hollingsworth, do you have any comments?
But
Okay.
yeah, so we're just speaking freely. I'd first like to say Dr. Robertson has done a lot for me and, helping me understand where we needed to be with compounding. And prior to Dr. Robertson coming in 2017 for the first time, we'd had some inspections, and going back even further than that, kind of where I come from, which I think needs to be discussed. I graduated pharmacy school in 2010. 2010, I started as a retail pharmacist only. This was an up and running machine, right? I came into Smith Caldwell Drugstore, had been in operation for a long time. They were doing compounding, doing sterile compounding, doing retail pharmacy. 2011, I go to aseptic training, start helping a little bit in the compounding lab, and I'm still working mostly retail. More and more, as closer to 2013, I'm doing more and more compounding, helping the compounding pharmacist as he's preparing to retire. 2012, September 2012 is when NECC happened, and that's when compounding world kind of gets turned upside down. So 2013 is Drug Quality Security Act. We're very knowledgeable of that, what's happening. December of 2013, I was then the only compounding pharmacist in the building. doing any of the compounding, sterile or non-sterile. And I voluntarily transferred every sterile prescription we had out of the pharmacy, all of them. Not a single one was done at that point, because I knew we had some serious things we needed to work on. We shut down the sterile compounding side and the majority of the non-sterile side to do a total remodel of our store. I had Travis Clean Air consultant, engineering firm, designed the room, our 4 rooms that Dr. Robertson explained. We were, at that to say, it'd be 8 years ahead of USP 800 being in effect. Had 800 rooms, both sterile and non-sterile at that time. Even did a remodel voluntarily without any direction from anybody on HEPA filtration, air, and et cetera, going into those rooms for the non-sterile side of those chambered rooms on our own. And that was in 2016, I think, is when we did that part, or the end of 2016. And Dr. Robertson came in the first time in 2017. So a lot of steps have been taken on my part to do a good job. And, as you read through these years of inspection reports and findings, that some I agree with, some I do agree with, things that I was doing that could be improved upon. There's no question. There's always work towards to get to a number that you never achieve. You never achieve 0 in sterile compounding. You just get as close to it as you can. And so I certainly agree that there's things that I need to do better. Having an outside consulting firm is something that I've kind of, now that I'm looking at an overview of this stuff from the last 3 heavy duty inspections, understand that I need to have an outside source of somebody to bounce ideas off of and make sure I'm interpreting the rules correctly. And I'm reading through these, books of USPs and chapters and things that get blurry really fast. So, and then at the same time, I'm the only person doing any of the sterile compounding, except for when I'm on vacation, and I had another person trained to go otherwise. So having an outside source is something I now see is invaluable to help with the SOP manuals and documentation and writing things down, because a lot of the things that are noted are things that I was doing, just not documented appropriately so that I could, have written proof or digital proof that these are what were happening. One example of that scenario is the employee validation testing. And I was taking the pictures of the plates. Well, on the plates, I got documented for not having lot numbers and expiration dates on the touch plates, but they're on the pictures, and saying that the pass and fail wasn't documented, but the pictures showed. And I apologize if I sent the wrong thing to Dr. Fain in my submissions request. All of my pictures of my staff or the pharmacy staff would laugh at me when I'd have all my vials lined up for the employee validation thing, trying to get a picture that had everything in one picture so you could count them, and then having close-up pictures so you could see the detail of the vials that were contaminated, that were the control test versus the ones that weren't contaminated. Like, I had all of that stuff. And it sounds like I was doing none of it. So that's, disappointing. But I see now that, there's got to be other ways to document this stuff that I can prove how it was done long term. So even years later, right? So documentation of extended dates. I would say a significant portion of my ophthalmics and things were all less than USP. 14-day refrigerated, 3-day refrigerated. A lot of them were 3-day refrigerated or never exceeded the 45 days frozen. The trimix injections, the substitution of the APIs that I did, or the decisions that I made there, I had articles that I had submitted from previous publications, like from Lloyd Allen or Compounding Today, things that they had published and referenced USP on substituting USP or NF ingredients that I submitted back to the board in previous years' inspections. I never heard back. So I sort of inferred that that was okay for me to do with PCCA in mind, where I got a lot of the formulas for the extended dating, where I got all my formulas that had extended dating studies done. And they did have the warning there, or the blue box, they called it, said not to substitute these chemicals or no substitutions or the study would be invalid. And I was very cautious on the decisions that I made to substitute because it came down to not having product or the patient going without their medicine. And I was very selective on when, if I would make that decision. And it wasn't just willy-nilly by the seat of my pants was I doing that. There was some decision-making processes that went into place there. And again, looking out from the outside, looking in at this point, I see that, just going without the medicine would probably be the better choice at this point. But that was a choice that I made, and it was not just a random decision that I did for the sake of money. And then I also had, speaking of that, I was an hourly employee. I could have stayed counting blood pressure medicine instead of going into compounding room, and it would have been, I wouldn't even be sitting here today. And there was no financial reason for me to push the envelope. I had no bonus. I had no reason to make as many Trimix vials as I possibly could, or anything, or do as much as I could without help. There was no incentive there for that to take place. And I want to make sure that's understood as well. I apologize, my head's kind of spinning with all of the things, but I'd like to engage in conversation and answer questions. If you had specific things that you wanted to talk about, I'd love to talk about it.
Trent, that last statement almost surprised me. So you got no extra incentive out of being
Zero.
but
I mean, I was an hourly employee. I got paid, fed my
Yeah.
family. I mean, it was a job.
but
My incentive was my reward.
Yeah.
I made sterile medicine for my family, my wife, my mom.
Yeah.
It's like, that was my reward.
But that side of most businesses drives a different type of cash flow than everything that's going through third parties. And I mean, it's generally, to me, and I could be completely wrong on this, because you have to consider the fact that there's a tremendous amount of investment in order to be able to do this and do it right. But generally, the margins or the profitability on the sterile side especially are generally a greater profit center for most businesses. It was just surprising to me that
It was, and I understood that the investment that Smith Caldwell made in our 2015 or 2014, our huge upgrade, I knew that was a lot.
yeah.
I sort of was hands-on with the entire process, so I knew where those dollars were coming from and going. And I never, I was just glad to be able to offer that to the state of Arkansas, to our community. And so I never really pushed for anything other than that.
And I can tell you that for me, having been at the board many years, and I've had a couple of questions on this of like, well, how do you determine when someone might need to come talk to the board on this stuff? And if you, when we look at it, there's a lot of stuff where step one for us is education or warning letters or something like that. And you could have single issues first time they're significant enough that you have to come visit with the board. But then the other side of that is repeat observations. And I know Dr. Robertson talks about, repeat observations from 17 and 20 on different things, or from 20 and then 23, I believe, on things. And if you want, we had to put all this in a spreadsheet to help, instead of juggling 15 different documents back and forth, You're welcome to have any of this. It's your documents as well. You'll see in red the ones that say repeat. And that way, if the board members have specific questions, you know exactly what they're looking at with that as well.
Yeah.
But I'm sure they've got some questions for you as well.
Oh, were you the only pharmacist doing the compounding, or you had other pharmacists?
There was one other pharmacist that helped me, very little, but I was 99% of it. Buying the chemicals, finding the formulas, quality control. It was me.
And you were also running a retail pharmacy?
No, ma'am, I was, at this point in time, I was compounding only.
Okay.
The store itself was a hybrid store, a large volume hybrid store, but I was just doing the compounding at that point. For the majority of my time there, I was just compounding.
Any questions by any other board members?
Yeah, I have a question. So I understand what you're saying, Trent, about taking pictures and thinking that you're documenting, but so there is some of that stuff in here, but how would you explain the repeat observations from 2020 and 3 years time elapsed and I didn't have that corrected?
Is there a specific one or just,
Well, there's several on here. I'm just asking in general, in general.
I always, dedicated as much time as I could, which was all of it, in my inspection reports or inspection responses, and tried very hard to make the changes that needed to be made. There was always things that we would redo, get rid of formulas, stop making certain products at the time of inspections. And I always thought that my lack of understanding at this point was I've made the assumption, which is not a good word, I guess, but when I made my responses and didn't hear anything back on certain ones, or I guess I see that would fall under the consulting side, right? That what I was doing was satisfactory. My responses were okay. And unfortunately, I've now learned that that's not what that means. So that's on me. That's a broad overlook at these repeat observations. Some of them, the master formulation, like the very first one, I took what PCCA said, if it was on the phone or whatever, I took that. And their logic and reason made sense to me when we were discussing these formulations. Like the cyclosporin, filters were breaking and their formula was not working. I was not able to make a good product. I never got to the bubble point testing side of that formulation because the filters would explode in the middle of the process, right? So I called them and we had a long conversation about what was going on, how it was being made. I talked to other compounders across the nation, people that I've met at conferences, et cetera, and we discussed how they were doing the similar product. And that's when, talking to Don, he said, well, it's a 50-50 mixture of caprylic triglyceride, which is a medium chain fatty acid. It's all anhydrous. There's no water in this compound. So you have to use oils. It's a medium chain triglyceride is a type of oil. So is castor oil. It's a heavy chain. It's a thicker oil. The purpose of castor oil being in that formulation is so that the contact time with cyclosporin is longer with the eye. And that's part of the benefit of using that medication is you keep the drug there for a long period of time. With the medium chain only, you have a decreased contact time, but still longer than it would be with a water-based eye drop. Was my understanding of the reason and the science behind it. Don explained, outside of warming it, which you can't really do because that also causes the filters to explode or break or malfunction. To use just the caprylic triglyceride only, not the castor oil, so I could avoid having to superheat or heat the formula at all to keep the filters from breaking. And his logic and reason made sense to me, and I documented that on the sheet, but I understand that I need to get things in writing and find a resource that can help me with those in the future.
If I could interject, just to piggyback on something he said, USP 797 allows for default dating, and it gives some flexibility if you remain within that default dating. The problem is when you start substituting things, when you're trying to reference a study that says you can have 180 days, that's where the rub is, if you follow what I'm saying, right? So if he defaulted to USP 797 dating, instead of extending it per a study that no longer is valid because you're substituting products, APIs and so forth.
But if you had extended study dating from PCCA, or I don't know if like compounding today would count, but they were using, no, didn't count.
I learned that from Dr. Robertson.
No, PCC, so from PCCA, and they list specific ingredients. You can go outside 797 as long as you follow their.
As long as you
compounding
follow
formula.
it, that was the
Exactly.
way it was. Now it's default. They've got default dating on category 3, limited. You can't go beyond those max. That's part of the update that happened in November.
And also, let's be sure we're all on the same page too. November 1, 2023 is when USP 787 was updated to category 1, 2, and 3. I did not transition to category 1, 2, and 3. I stayed low, medium, high And I was going to do so until November 1 and then make the transition. There were things that I was doing to get ready for that. For example, stop doing membrane filtration testing for serum tears. I'd revamp my process, my dating. I short dated all of those serum tears products to not exceed category 3 USP for the new chapter that was coming. But doing so also kept me within the high risk of what was in effect, what was in law. And that's why I made those decisions for the serum tears product. That one was one that was near and dear to me because it did a lot of people a lot of good. And you asked about the virology testing and stuff for that. It brings up that point. I didn't do virology testing
Did
on
the
the
lab
serum.
do it for you though?
No, they didn't. I treated all of them as if they had everything. That's why we did bloodborne pathogen training with OSHA. We did a lot of steps to protect and take care of things. And I only made 3 a day at a max because I had to have certain amounts of time to bleach and decontaminate the hood. We had dedicated equipment. Very little supplies were reused. The only thing, in fact, that was reused between patient to patient was me and the stainless steel hood itself. Everything else was disposed of, decontaminated, cleaned in between. I didn't label the bleach dilution bottles that I made. I used the branded name Clorox because it had the highest percentage bleach. And I followed the bloodborne pathogen training on OSHA for blood spills. I treated everybody like they had everything. That's the way I treated all the serum samples because patients couldn't afford it if I did virology testing for $1,000 on every serum tear sample.
Yeah, I get that.
And
I
the
think
lab
you- I
treated
think
it-
you could have leveraged demanding it from the lab.
Well, the lab treated it a certain way, and I had 2 eye physicians that sent me serum tears prescriptions, and I had a conversation with them before I ever started doing it, way early on, and I told them about the virology thing, and both of the physicians told me, and they were at the same clinic, that they would not send or recommend a patient to be a serum tears patient if they had issues, hepatitis, HIV, et
How do they
cetera.
know though? I mean, again, but this is probably not germane.
It
to
was
the inspection,
a
but-
very tight relationship I had with those 2 prescribers, and we worked very well together for many years. And so I treated everybody like they had everything. That's the way I looked at it, and that's the way I treated those serum samples to prevent any cross-contamination, any issues with those patients. And a lot of times I'd be backed up. I'd have to schedule patients out and they would go without medicine because I refused to make an excessive number of serum tears prescriptions in a certain amount of time because I had to have steps in place for me and for everybody involved, all of the patients. So
I wanted to ask you just real quick so were you batching, like, did you do your serum eye drops in batches for different patients, or was it all just a one-off? You do it for this patient and then the next day you do it for another patient?
I would sometimes do multiple in a day.
How did you do it in just a horizontal, in your non-hazardous room, a horizontal hood, or?
No, this was all in my ISO 7 room, but I had a dedicated hood in that room that was used for only
Your negative pressure or positive pressure?
positive pressure. It's a positive pressure room. It was not a hazardous chemical. It's a biohazard. So blood is a biohazardous product. It's not a volatile powder that's getting blown all over the place. The hood itself was a hazardous containment hood. So it pulled air a certain way, and it was HEPA filtered air coming in. So I did my hand going up. That's incorrect. So the HEPA filtered air was coming in, but the hood pulled the air in. It didn't blow back into the room or back into me. It was pulled back up and recirculated.
And what were your cleaning procedures after each?
So the sterile room itself,
I'm just asking, okay,
For-
room and hood.
so it's for this particular scenario for serum tears, it's a mix of cleaning procedures. So I treated bloodborne pathogen a certain way, and then after the cleaning procedure was done, I used Pharma-D or sterile isopropyl alcohol to clean the hoods after the bleach process was done. But you would let that 1-to-10 ratio of the branded name bleach that I would mix the first of the week, every week. I did it myself. I was the only one that did it. So I knew when my bleach bottles were mixed. And Cindy got on to me for that. Dr. Fain got on to me for that, for not having them labeled. Because she could look in there and see the bottle that was being used and see the isopropyl alcohol over here. And she didn't know which one was which. I did because I mixed them. I can tell one was yellow and one was clear because the bleach is yellow when you light the other anyway when you mix it. But I knew that. And she didn't. But I
Did you
used that,
decontaminate between patients?
yes.
Okay.
Yeah, and there was a certain, you have to spray it down, or not, you have to wipe it down with a saturated non-linting cloth, let it evaporate, repeated that step. And then you could come back and clean with sterile isopropyl alcohol, disinfect prior to making the next batch. But so it took a lot of time in between each patient.
Okay, thanks.
Dr. Richmond, did you have any?
Dr. Hollingsworth, I'm asking out of ignorance, what was the volume of compounding that was actually coming out of that pharmacy? And I'm sure we have it in our records, but I know if you're talking about, serum tiers being quite complicated and limiting that, but still being backed up, if you're doing 3 of those a day, in many ways, it would sound almost like that would take most of a day to me.
No, yeah, it was very rare that I would get backed up, but it did happen. Most of the time, I would say serum tiers was a small percentage of the total number of prescriptions leaving the pharmacy for sure, but it just took more time. But
if you're doing that and doing Trimix and other sterile, from
different
powder to
days,
sterile,
like I would separate them by days in that scenario. I wouldn't do Trimix the same day I was doing serum tiers, 90% of the time. But
it's like how many non-sterile to sterile compounds were you doing a week?
that's a good question. I didn't run the reports like I've learned to do now. I didn't track that data too tightly. I know we were doing, I think one of Dr. Robertson's requests for data I was looking at earlier this morning from 2020 was he wanted a 3-month window and it was like 1,000 something prescriptions or something. And I was like, are you sure you want all that? So
Okay.
that was RX is sold, right? Or something like that when I ran that report, but
So 20 a day. It'd kind of be
the
an
ones that were
average.
leaving the door, yeah. So like in the batches of Trimix was the largest or most complicated thing that we did, at least there at the end.
But you'd batch those to make.
They're done by batch, yes, sir. And so the retail pharmacist would help with the selling and counseling and discussions with the patients, but I made them and verified it and did all the quality control stuff on my side.
So on that, you would, at the end of it, you do your bubble point test to prove sterility. Were you sending any of that off for
That was all
validation?
sent, yeah, it was sent to Eagle Analytical. I have in the past used multiple labs, but that got too cloudy for me to keep up with. So everything was done with Eagle Analytical and all the Trimix, anything that was extended dating, anything, always got endotoxin tested. Well, it's not exactly true. It's like Trimix wise was endotoxin tested and sterility tested. Endotoxins were always below a readable level of less than 1 EU per milliliter. At least all the ones that I can remember. I never failed a sterility test on a product.
And then you're doing potency on the batches of those?
I would do skip lot potency testing. I didn't do them on every single one. There was an alprostadil, a sterile compound that had to be made prior to the batch of Trimix being made. That was a PCCA formula for that. And I would do endotoxin potency testing on that one. Because that's the one where, in my experience, we're making it was where you could really get off because the alprostadil component was measured in micrograms.
Yeah,
very sensitive and a very potent drug. And so I would do potency testing on my 500 microgram per milliliter dilution at the same, and I did sterility endotoxin on that one as well, even prior to making the Trimix. But that way I knew when making my Trimix formulas, I knew how much to use and I could get it.
So when you batched it, how many units were you batching on the Trimix?
We would get about 95-ish average vials out of my fat hands. I'd knock over a vial or two sometimes and I would lose some, but the math would say 100 milliliters, but often it was.
Yeah, you'd lose
some. The real
some
world is 95 vials.
Version hoses.
95 2-milliliter vials, yeah.
But you're familiar with our rule that you have to do sterility, potency, and pyrogenicity testing on any batches of 25 or more on high risk.
And I did endotoxin testing on those.
Well, it's all 3: sterility, pyrogenicity, and potency. It doesn't just say just pyrogen testing on batches. It's all 3, unless I've misinterpreted it for years. Yeah. So on that, when you'd prepare it, you get your alprostadil, and so you'd validate it before you used it to continue on in your compounding process. And in that, so you had dating on your base ingredient for alprostadil. Did that limit your dating on the final product, or since it was
Most of the
final
time-
filtered, you could
So the
further expand?
trimixes were limited at 60 days refrigerated. The alprostadil at that time, prior to the November 1 rule, change of categories, it had a 180-day date from PCCA bracketed study. So most of the time, if it got to where it limited my trimix dating, I would scrap it and start over.
Do a new batch. Okay. So what was your procedure for quarantining products while waiting for testing results?
We had a designated spaces in the lab where things would go when they were in quarantine, big neon stickers like that would say quarantine, do not dispense. And then when testing was completed, I printed off documentation for that, stapled it to my formulation record, hard
And-
copies.
And to clarify, you don't mean in the compounding room, you mean just in the compounding section of the store outside of your ISO 7.
Yeah, correct, yes. Not in the compounding laboratory itself, but in the office area, so to speak, where my
Stored area.
refrigerator was or whatever.
Did you, knowing a little bit about volume, I know you've said you're the only pharmacist that did all this, which I mean, that's, to me at least, that's a lot of compounding. What kind of support staff did you have in that? I know you had some techs that you had trained that you were overseeing.
I have a technician that helped me with non-sterile compounding.
Okay.
I didn't have any technicians that helped with sterile compounding.
All right. So there's all pharmacists on the sterile side. I know in some of the responses it talked about further training and realizing, and it's a statement that I know we've agitated some people before when we say it, but it's, we try our best to help and answer questions. It gets to a point where it's like, we can't be a consultant like full on because it's, we have limited staff and resources as well as that's a cost of the business. Did you feel like whenever you needed that was always available?
Yeah. I mean, I could. The tricky part was being off work or leaving, taking the time, when I requested to go to a training or aseptic class or whatever, I tried to do as much of it online as I could, webinars and those things, but I would go to conferences pretty often.
And that's what I was getting at. So you had, financial and time off support for that. What conferences were you able to attend that employer helped with?
I'd go to the annual conference with PCCA pretty regular, and there was always sterile stuff that would come up with that. Matt Martin's their quality control director, and he would always have presentations there. I tried to attend as many of those as I could. Where was that? Usually it's in Houston, PCCA. Yeah.
Yeah, they have a facility at their headquarters for training, and
I go to LP3, and I did LP3 classes through Mediska as well, trying to get different people's takes on stuff.
so, and when you bring in, were you the only pharmacist responsible for the non-sterile as well?
Yes.
So what was the non-sterile volume? Because I mean, it was all the hormone replacement, topicals, creams.
Yeah, it was probably less than the sterile side. I don't remember the exact, I didn't run those reports very often to see, but it was, my technician was very good. She's still with me today. So she's, one of those, it'll be hard to replace, but without her, it wouldn't have been feasible for sure at the volume we were at. But, I had pharmacists, two at Smith Caldwell that were very knowledgeable with the hormone replacement therapy and the processes. And so they were able to shield a lot of the phone calls and consultations and those things.
Well,
and they were very helpful with that part. But as far as the formulations and being in production and quality control checks, math, all of that stuff was me. But
so you were and that was going to be another clarifying question for me. So you were mainly on the non-sterile, at least you were on the production side, not the patient interaction, patient counseling, and
Right.
setting up appointments for all that. And I'll say this, I believe it's a safe statement for our board members to understand. I'm asking some about the non-sterile side. The concerns of board staff are around the sterile side of that operation. The non-sterile, we did not have the problems with, and part of that is for me, and Dr. Robertson and I talk about this a lot, when you start talking about areas of risk, in general, if you have a manufacturer, in theory, it's the lowest level of risk for a final product. An outsourcer would be more potential risk than a manufacturer, just due to the way that they operate and their oversight. And then a compounding pharmacy has less oversight and follows a different type of rules with 797 versus CGMP. 797 USP guidelines are very much, to me, and I'm not the expert in this, but it makes sense to me this way. They are the cookbook approach of follow these exact directions for a quality product at the end.
First part of your sentence again.
It's a cookbook approach.
No, before the who?
USP guidelines. So whenever you're dealing with a compounding pharmacy, they're using USP guidelines that are a very direct step-by-step. Here are all the things to do to reduce risk the most, to have a final product that is of quality, that is sterile and as it should be labeled. With that, and this is part of Dr. Jolly's question, to go outside of the normal sterile beyond use dating or anything else, you had to have like validated information on how you could extend that date. So when we face this several times, this isn't just a Dr. Collinsworth thing or with the store. When ingredients are not available, like if you generally would call, PCCA or Medisca or Letco or whoever you're getting your chemicals from, they would say, we used our chemicals or our source chemicals, and this is the thing that we spent all this money for this study, because it's not cheap to do, to prove an extended beyond use date. This is all before November of 23. This is kind of the older way that it happened. And we've seen, and the board has seen examples in the past where people go, well, this is great. And I don't mean this is a disparaging comment, but this formula that these people spent the money to prove gives me 180 days, but I can't get their chemicals, but I can get these other chemicals and I'll just use that. Well, if you're in your kitchen, there's a difference between, self-rising flour and, a different type of flour. You may have a 1-to-1 ratio and you think you've got the same chemical if you switch to gluten-free flour or something, but it's going to bake differently.
Can I build onto that? Is that okay? So substitution of the papaver and hydrochloride that I did with Trimix, whenever PCCA would not have their product for an indefinite amount of time, they couldn't give me a time when they'd have it back. That's papaver and hydrochloride going into solution. It was a USP to USP grade substitution. It's interesting to me, not against PCCA, but whenever they would mention these conversations in conferences and stuff, they always talked about progesterone wettable powder versus progesterone USP, which any of us in the compounding field certainly know there's a gross difference in how those two, they have the same CAS number, but they're not the same thing. They're different particle size. So going into a cream and a troche, it's a different process than making something that's going into solution. When a chemical dissolves into solution, it dissolves into solution. And if it's USP to USP grade, and I built off of Lloyd Allen's publication with multiple USP references about substituting USP grade to USP grade. So Dr. Kirtley's correct. These companies say those things and very strongly advocate for that. And it's justly so in some scenarios, and then sometimes when it's like these things going into solution to solution and it's USP grade to USP grade, I feel like it gets pretty washy. Making a cream and a troche with progesterone wettable powder versus progesterone USP, chemically understanding in my mind is very difficult to understand.
But on these, we're talking non-sterile powder to a sterile final product. So understanding the different structures, that's where you can also get into issues with how they interact with your filters and stuff.
I would just add on that because just the level and the amount of training that I've had to go through with the FDA and all this other stuff to get, and I still learn every day, and we all do, that's in compound, that deals with any of this stuff. But when you talk about USP grade and everything, I will tell you that just like when I went through FDA training, some of the stuff that happens sometimes, they'll say it's USP grade. I remember one example they gave us during training was there was, and I think it was related to when ranitidine and all that stuff started having some issues with the carcinogen in it and so forth. And it was because they were taking drums, they would get 50-gallon drums or something, they'd say it was USP grade, and they put the good stuff on top, and then they would put this other lower grade stuff on the bottom. And so they had to start telling them how to sample a batch differently and all that kind of stuff. So that's why when you start changing all that stuff, there is a reason for it. So sometimes you just kind of think, well, it should be the same, but then you don't think about those things like that. And then you talk to the FDA folks that go across to India and China and inspect these plants and these APA plants, and they can tell you the good ones, and they can tell you the bad ones, the ones they worry about, and you know, it's kind of like our sidebar type conversations. So anyway.
Dr. Robertson, this inspection from 2023, this wasn't based on the November 1 update. It was based on the previous guidelines. Is that correct?
It was. Now, the reason I had brought up things about the response saying that it didn't include those things that were going to go into effect in November, is because I inspect around 140 hospitals that do, most of them, about 90% of them do some level of compounding. The majority of those had already started to convert because it was easier to convert instead of trying to do it at the last minute, because you've got all that testing and all that stuff and all those policies and all that stuff that you got to get done. So yeah, that inspection was done under the old standard, but people were already in the process of converting. And so that's why I made the statement of related to what the new standards were.
I was legally,
That's true.
I'm legally fine to follow it until November 1. Okay. Because that was my understanding. I talked to other compounders in the state and out of state, and some of them had switched and some of them were waiting to the last minute of switching. And I was like, they had two different desktops, and that's kind of what I was following. I was building my formulas and doing testing, but nothing was in place. I had a separate PC almost that was storage of those data, like serum tears. I had transitioned unofficially, but I had transitioned it to where it would fit, you know, but it wasn't documented as being category 3. It was just the dating and stuff was done for that such. And I didn't provide those responses in my responses because I knew as I was typing these responses, I was pretending in my mind like I was going to be compounding, you know, after the store closed on August the 16th. But because I want to still do sterile compounding at some point in time in my life, I knew it wasn't going to be there. So the responses for my 2023 inspection were challenging for multiple reasons. My whole world had been flipped upside down a week prior to that. So,
But there were no observations that were observations as a result of a conflict between new 797 and old 97. I mean, there were no.
No.
Yeah. So I want to see if my line of thinking is correct on this. So manufacturers are subject to CGMP, and that's the responsibility of the FDA to oversee that. USP guidelines are everybody else. And that's put on states to govern, right? Boards of pharmacy. So 797 in general is not meant to validate an end product. You got to have all the processes in place I'm trying to word this in a way that makes sense. You got to have, you need to validate your processes by having the right processes in place, because you're not required in general, unless you go outside 797 guidelines, to validate your end product, where CGMP is a little bit different in that it's the validation of your end product.
Yeah.
That's the focus. Is that?
I would say maybe what you're trying to get at, and correct me if I'm wrong, is, and this is how I kind of explain it to people, is 797 is trying to be a lot to a lot of people in a lot of settings, and it's trying to put everything in a column and a row. And sometimes when you get into sterile compounding, it's hard to put things in a column and a row, and you're not trying to put the burden of CGMP, what really, is CGMP on somebody that's doing low volume things. And I'll just kind of give you an example of one I remember. I was accompanying a FDA inspector at a facility that was a repeat. They were there because the previous owner had issues with the FDA. And so they were going down the road of CGMP. This was in the early phase when they hadn't really kind of softened their approach to that's a pharmacy and they're not making bulk, large volumes. And so it was a home infusion place. And so they went down the road of, they wanted people to do, they were going to write them up on not doing glove fingertip tests every day, which is way outside what USP 797 is. And so having a conversation with that inspector to kind of give them, because they weren't a pharmacist, they were, I think it was a veterinarian. And I had said, look, here's what we've got. We're not talking about somebody making 10,000 doses of something and giving it 6-month expiration date or 2 years. We're talking about somebody who's making a couple of TPNs or sending to somebody's house, and they're going to give it 14 days max. So the reason I bring that up in the context of your question is that the expectation of CGMP, where you're making that 10,000 doses, and if you look at the CFR 210 and 211, that's a very small. If you compare it in volume to a lot of other regulations, it's very small because it's very vague. And it's very vague for a purpose because you have to validate, and how you get there, they kind of give you the rope and let you do how you're going to do it. But the expectation is that that process, because of all the complexity and the amount of people that will impact downstream, is very rigid. Whereas with somebody who's doing USP compounding, if you're staying within those parameters of the default dating, they give you a lot more flexibility to do that because you're not varying into manufacturing. And you wouldn't be, because you got such a limited duration for beyond use date. And so whereas in the CGMP, where if you're even going to go into a clean room, you got to qualify yourself, and your eyes are the only thing. They're covered with sterile goggles, and because you've donned a sterile bunny suit, and they've made sure that you know how to do that with Petri dishes and everything, versus we got skin exposure in a USP 797 operation, and we are the worst part of a clean room. The limited default dating on beyond use date is they see it as a balance for the volume. I hope that answers your question.
It does.
Okay.
But when you go in and do an inspection for sterile compounding, you're bound to inspect by 797 or other USP chapters as they're applicable, right?
Correct.
Because we're not validating an end product. We're setting up our processes so that our end product is where it needs to be from a sterility standpoint.
Correct. And sterility and stability, right? If you, whatever the shortest of all those are, because there are certain things like stability indicating assays, because there's byproducts that can occur and those type of things. It's not caught by a potency test.
But that's why when the board, even before I was here back in like 03, 04, when they even established some of our language is antiquated on high risk, if you're batching batches of 25 or more, sterility, pyrogenicity, and potency testing are all three required on those products. Now you can do, most people are going to do the sterility by the bubble point. They have pyrogenicity testing that they can do, which is pretty easy. But then the potency, and part of that was because the board had some sub-potent, more so I think than anything else, products that I think we figured out was because people were microwaving stuff to heat it up, and it was actually breaking apart the chemical molecules, which was a kind of a mess. But that is something we had above and beyond USP guidelines, even when they were originally introduced and effective in 04, that's been left.
I guess my overall point is 797, 800, all the various chapters are not easy to adhere to, but that's what we've got.
Yeah, I mean, if you talk to folks who are a lot smarter than me and a lot smarter than a lot of people in this room, they say it's a minimum standard. It's a minimum standard. Like, for pressures, let's just say, talk about pressures for rooms. You see a lot of people shoot for 0.02, even though you can have a lot higher in your exchange rates. And the higher your exchange rates, the less likely you're going to have contamination and all that kind of stuff. But it's a minimum. USP 797 is a minimum.
One more thing I thought about, there was one of Dr. Fain's findings was a complaint in the letters, and I forget where it was, the verbiage documentation that I received back. It sort of reads like there was a patient complaint that was filed against me with the board or something. It was a patient complaint that came to me that I documented myself about my product. And it was about an eye drop bottle and the difficulty of the bottle to use for that patient. I offered to revamp it, retool the container, for her to bring the bottles to me to review. She didn't bring the bottles in. I never saw her. I tried to call multiple times and documented that. I even went a step further that I didn't document that Dr. Fain spoke to me about that I should have was I called other patients that received that same sort of time frame of bottle to make sure nobody else had any issues. Nobody had any issues. This was specific with serum tears. And she told me I should have documented that. And that's what she wrote up in my inspection reports, that I should have documented the conversations outside of that patient complaint saying that I had investigated it. But the documentation, reading the report or reading the inspection survey is like I didn't adequately follow through with the complaint. I felt like I more than adequately followed through with the complaint and tried to help that patient as much as I could. And she never came back with the bottles. I offered her money back, redo it all, start from scratch, et cetera. Never saw her again. And then also building on to the issue with the container closure tests that I was written up for in 2023 for the serum tears bottles. Those bottles are very unique. And I spent a lot of time with Eagle on the phone deciding what test to run and how to run it. The container closure test was to prove that it maintains sterility of the nothing was able to get inside that bottle during use. And those bottles, they're a Novelia bottle, FDA approved container. They have a very unique flow chamber where the solution comes out of the bottle and goes out of the eyedropper dispensing into the eye. And then it's it back filters when you release the bottle, and that negative pressure pulls air from the atmosphere into the container to neutralize the pressure inside that bottle. There's a filter, and that process works. It's very unique. It's very different. We were able to use that bottle to do a preservative-free multi-dose sterile compound. And I had that bottle tested to prove that nothing got inside that bottle. And that was the test that I discussed with Eagle when I sent that off to them. I know now things should have been done differently, but that was something that a lot of thought and effort went into how that test was ran, what solution was in that container at the time of it being run. I thought I did it the right way, but certainly that's one of those things where I needed an outside consulting person to another person, not the person doing the test, not me, somebody else saying green light, red light, kind of situation. And I see that now, but it kind of makes it sound like things were just kind of done willy nilly, and it was never the case with me.
Are you the PIC?
No.
Okay.
The only thing I'd add on to what he just said about the eyedropper, and he's right, it's a unique kind of device. But before he started utilizing that, you were dispensing a large volume of a product from a regular eyedropper and considering it multi-use and didn't have that. And that was a write-up from a previous inspection.
That was a previous inspection, yes.
So it was really should have been single use, but it was dispensed as a multi-use. And so as a finding, he started using that product.
You talked about having training and going through some aseptic technique training and that type of thing. And I think we have numerous inspectors and several of us that have been through a lot of training. And one of the things we're always told in training, if it's not documented, it didn't happen. Have you ever heard that before?
I have.
You have heard that. So if you didn't write it down, if you talk to somebody at PCCA, but you don't document it, then it didn't happen. There are guidelines you have to follow through USP to make sure that whatever you're putting out there is safe for the public. Guidelines and the rules and regulations, not even guidelines, but laws and rules and regulations about potency, sterility, endotoxins, all of that you weren't following. And when you come back around after all this conversation, there's still 9 observations, repeat observations, plus the other observations that are on this inspection that you talk about being trained. Some of these happened in 17, and Dr. Robertson obviously said, when I first started, I tried to teach and get people up to par. But then you have 20 and 23, and you still have repeat observations. Those should have been fixed. And I mean, for whatever excuse they weren't, It's your obligation as the compounder to know what you're doing, how to do it, and make sure you're doing it correctly. And I think we have to remember that part of this conversation.
I agree.
That was a comment I want to make. You kept having these repeat things over and over. And I wanted to ask you, what have you done to bring everything up to par now? But have you done anything?
Nothing, the store closed a day after the inspection was done. So, I mean, moving forward, it's more of a high level revamp in my mind. So it's, I'm doing non-sterile compounding only at this time. And I've built off of this when I was started over at a new facility. And, my whole approach to compounding sort of as a new light shined on it with the regulation side, documentation side, like Dr. McCready just said, it's, I've rebuilt SOPs from scratch, started a stronger framework from the ground. I'm not walking into an up and running machine that I'm trying to rebuild as I'm working, which is what I guess I felt like a fire I was fighting the whole time, but at the previous store. But my mentality today, even with non-sterile compounding, is much different when it comes to training. And the new 795 chapter for non-sterile compounding also was revised and came out November 1st. And that there's a lot more documentation required there, like Dr. McCrady's referenced, that it has to be in stone, solidified. Things have to be done a certain way. And I'm not doing any sterile compounding. The day I got the warning letter, I stopped it all, period, even though I knew the store was closing a week after that or whatever it was. But I shut it and I didn't sell anything else, period. And moving forward, it would be a much stronger framework from the ground prior to making medication. It would be other guidance outside of me interpreting the rules and trying to do the things in the production side as well. And I would need to rely on other resources to help me make sure I was in the lane.
How long have you worked in sterile compounding?
I would say probably 2012-ish, 2013 is when I started doing it.
How much of your time in a given year would be dedicated to sterile compounding? Would that be your full-time job?
Yeah, I would say more than 50% was for sterile versus non-sterile.
So say that you've got well in excess of 4,000 hours of practice in sterile compounding.
I would say so, yes, sir.
Education that you talked about before, it sounded like the only one I heard you mention by name. Okay, but are there other places that you have gone?
There was a LP3. I've done some LP3 training. And a lot of times I would go to like a vet specific training where we would talk about aseptic stuff at the same time, but never, it's a lot of overlap there. So not aseptic specific that I can recall. We did the ASHP online stuff every year, but that was not like an in-house sit-down training.
Do they only have online?
Not only, there's just a lot more of them available. So a lot more and easily to access for somebody like me that was one-man band. It's easier to get the training.
Obviously, this practice is highly sophisticated and peculiarized, and I don't expertise in this area, but I'm just thinking in terms of our conversation with Dr. Holmesworth relates specifically to his practice. And I think the notice of hearing indicated that we were asking that he be made ineligible for compounding. But I don't know that we're wanting to impose that on him forever. BPS has a board certification, and I'm not suggesting that you need to become board certified, although if this is what you want to do, that certainly would be.
I agree. And it's something I've always been interested in. And when I started looking into that, it was when we knew the new guidelines were coming out, the 797 revision. And so that was kind of what, prior to the Smith Caldwell close, It was certainly something that I wanted to accomplish. I'd even had some conversations with some classmates of mine that had done that. But I was waiting. I wanted to have some work time under my belt of the new regulations prior to sitting for that.
But I'm not advocating for any one organization's training programs, but I do know ASHP is a approved provider of continuing education for the BPS certification in sterile compounding.
Yes, sir.
So it may very well be that that would be another excellent source. I don't know, is PCCA compounding, is that more product specific?
It was more processes, not product specific. It was more, cleaning processes and first air, where your first air was coming from, and understanding different types of laminar flow versus horizontal flow hoods and solutions and et cetera.
Dr. Richmond, part of that is, this store has shut down. He's not doing any sterile compounding at this time. And, I think from the staff perspective is we weren't worried about his non-sterile compounding. We may not be worried about sterile to sterile if he wanted to do home IV, but if he was wanting to go back to the highest level of risk of the practice of pharmacy, which is, non-sterile and non-sterile powders to sterile, if the board told him now, you cannot do this now, if at some point later in his career he came back, he could come back and explain to you what other training and what would be different going forward. There's no action to limit what that pharmacy can do now because it no longer exists.
Well, and I
So
was trying to
it's different.
specifically relate to him.
Yeah.
I do think the ASHP program, my understanding is it's a partnership with the Board of Pharmacy Specialties, BPS. I think it would be a standard in terms of, I'm not aware of any other, unless you are, I'm not aware of any other more intense,
Oh, yeah, there's more intense programs. I guess what,
that's available to like someone that's working full time.
well, you can send people off for full-time training for,
Okay.
I mean, when I went to FDA training, I was gone for 6 weeks.
FDA training though geared toward regulators or practitioners?
Well,
Well, you can't send somebody. to
yeah, he's not going to be able to go to
Yeah,
FDA, but
there are entities that exist that when you start dealing with the complexity, and I forget what the name of this one particular one is because I've never been to it. But most of places that make things from raw powders to sterile go, it's just being able to, as far as board certification, I can't speak to that and how it would apply in this kind of setting. I don't have a hospital that makes anything from non-sterile to sterile anymore. And so how much ASHP, I don't think a lot of hospitals do that. So I don't know how applicable it would be. I can't speak to it. I've never participated in that training to know if it would be any help with this.
Don, do you know who sponsored the certification to BPS?
I'd have to look, but I know that, they've had that one for a while and I would bet that it is
About
partnered.
1,600 people.
Yeah, it's one of the older ones that they've had at
Well,
BPS.
if we're talking about board certification, it's like you said, it was maybe there's a partnership with training. ACCP used to be the partner with it. It's BPS. It's the Board of Pharmaco Specialists. And so that they're a standalone entity. And they're the ones who, and that thing's been out probably maybe 5 years that certification has been there.
Well, each certification has its own recognized education providers. For example, the geriatric one
Yeah.
was ASCP and ASHP.
Yeah. I mean, I was board certified in pharmacotherapy for years, 14 years.
That's an ACCP sponsored.
Then it became one that was co-sponsored between ACCP and ASHP. And probably maybe 7 years ago or 10 years ago.
There are other organizations that do have training for higher level stuff like this. Most of our people have been through like critical point type training for the oversight of it. And critical point, at least used to have in-person training for the preparation side, just like they did for the oversight side. So it's out there, but it's one of those where I can't necessarily draw you a roadmap, but if you are wanting to get back into that, you can show me everything you've done as proof where it's meaningful.
Yeah, and I guess my thing would be if um, is that like on some of the things, it's like you got the attention to detail of even like we talked about the media field that I had stated earlier. Media field in his response said 48 hours and at time, at 30 to 35 for 48 hours in 2025. And and maybe people don't see that's a big deal, but it is a big deal because that's how you elucidate if you're doing, if you're using tryptic soy, then you have to do two different temperatures because of bacteria versus fungal growth. And that should have been included in the appropriate in the response. And that, so I guess that's my thing is you can go to all this kind of training, whether you get anything out of it or not, I don't know. And how do I assess that? You see?
So, with the FDA inspection, I know it's a different beast, but when they get a warning letter and then they submit a response, do they get a response back from the FDA at that point? Of saying, yes, that's sufficient. No, it's not sufficient.
The FDA might do another shorter follow-up inspection. The first warning notice that we gave was 2020, obviously was during a COVID and all that kind of stuff. But it depending on the response for FDA, whether it's just if we're just doing this as a comparison, how they approach it is they may have a response. They don't like what you get. They give you a warning letter. And then from that warning letter, it might even progress to an injunction.
Yeah, I think along the lines of what you're asking, you don't generally get a clearance letter from your response. You generally would see potentially some ongoing either further inspection or potential feedback of.
Yeah, so like, for example, if they have an inspection, let's say in 2019, and they have warning letters that are issued and follow-up inspections, once they feel like that thing is finalized, they will issue what they call an EIR, an establishment inspection report, and it gives all the detail. I think it's 145. But then again, I have seen them issue a EIR one day and then come out and inspect them and issue them another warning letter 2 months later. So it's just on different topics, or it's repeat finding from the previous ones
Well, my question was more just, if we're having repeat issues and we do get a letter back from a pharmacy, is there a way to say, no, that doesn't pass? Yes, it does pass without being a consultant role, like what you're saying. I know time-wise we can't be a consultant in every pharmacy, but can we give them feedback of saying sufficient, not sufficient?
Well,
And you may do it already. I just don't know about it.
generally what we hear is, here are all the things I'm going to do to be sure that I am fixing it and it will not be an issue in the future. So then we go back and we re-inspect. And then the re-inspection is, look, this isn't fixed. So where it gets difficult for us is you can tell me you're going to do this, and we could even say that should be sufficient, but then when we walk in, it may not have been sufficient because it's talking in the hypotheticals at that point.
I have a question. Why did you not do the changes? I kind of have no problem with that.
Yeah, I can see that. So like a repeat observation of the 1-page employee validation is two pages or 2.5 pages. I did make changes, and I submitted those responses back. Formulations were updated, times were added to when formulations were done. I always tried to make the changes and documented them and sent my responses in. There was times like with the germicidal thing, I will admit issues there that I should have done a better job of my rotation and what chemicals I was doing a cleaning and disinfecting with, instead of using just isopropyl alcohol one day and formaldehyd the next. And I was doing the sporicidal agent on a monthly rotation, fixing a transition to a weekly rotation in November 1. So I did make a lot of changes, and it's not really reflected very accurately in this spreadsheet, and certainly with the red, bold, repeat observation, kind of the high level overview, but there were changes that were made. there was still some issues. I will admit that things that I could have done better. There's no question about it, but, employee validation was one I worked very hard on. Even though I was invalidating myself and one other person that was barely part-time, but I still tried very hard to document all of that correctly and adequately, but,
Did you get overwhelmed with your job? Was
Yeah.
it too much for you to do?
it was a lot.
You should have got a second pharmacist.
I mean, I had asked for help, there towards the end, maybe in 20. Gotta choose my words carefully. I'd asked for some help with, I knew quality control was getting very difficult and was going to get even worse after November 1. It was going to be insurmountable. There's no way I could have done it by myself after November 1st, 0% chance. I probably would have left at that point. I'd asked for some help and I was told by other personnel that, it would just be come out of my paycheck kind of deal. So fortunately the store closed and I never had to get aggressive with it, but
you didn't own the store. So I'll tell you, that's what I was trying to ask earlier is, I have not practiced in the realm of sterile compounding, but I have definitely not practiced in the area of high risk sterile compounding with all of the extra attention to detail you have to have. So when you're telling me that you're doing 1,200 of those every 3 months, plus you're doing all the cleaning basically by yourself, the serum tiers, things like that are extremely complicated. You have to do a re-clean between every set to where you can only do a couple of them theoretically a day with other stuff going, and that you're in charge of the non-sterile side of a pharmacy. Like we will often see, or I feel like, that you have a pharmacist that is concentrating in over a significant non-sterile business. Do we have, I mean, most sterile businesses that I've seen in my 20 years here, it's never just one person, or it never seems to me like it's just one person. Am I off base with that?
Are you specifically talking about sterile?
Sterile.
Again, because of, most of the sterile that I see is in a hospital, so absolutely not one person. I mean, there's some places, there are smaller facilities that would have maybe one pharmacist, but they do very little compounding.
And all that's sterile to sterile. But I mean, all of our home IV pharmacies, I'm looking at our other inspectors, all of our home IV, all of our other people that are doing sterile stuff, it's multiple people. They all have help. It's, you always have a backup to the backup. You have a second set of eyes. You have a second set of people that have expertise in it to help fill gaps at much lower volume. Yeah. So, and that's, I can tell you that I would not be comfortable trying to do that level of volume and building it up as one person. And, I think that, at least for me, that's part of the reason why, I don't know if it's correct to say the kindest thing, but in many ways, the kindest thing is to say, well, we don't want you doing this area of practice unless you come back before the board and discuss it. And we know what the approach is going to be and be sure that you have everything that you're going to need. Because in many ways, I feel like you had a task that even with all the effort you put in, like that was more than one person should be saying grace over. So that's kind of why I was asking you that earlier. You were able to get training, but you can't go do training if you've got no backup. Like you can't say, there's this amazing training. It costs this much money. It's an investment in this business, but I got to be gone for 2 weeks to do it. So it's 2 weeks of my salary and it's 2 weeks of paying me to be somewhere else for the conference, for eating, sleeping, and it's 2 weeks of someone else having to cover this or shut down this money line of the business. If you're the only person doing it, that's an impossible ask.
Right. And like the Trimix patients, don't want to say that wasn't life or death necessarily, but the ophthalmic side, that was one to me that was very hard to shut it down.
Yeah.
Because like I said, those eye doctors and myself had a very tight relationship and they certainly needed me. And that was one that I had a hard time with walking away from or closing the lab down for a period of time to go
Well,
do stuff like that.
How'd you take a vacation? I mean, it shut down for a week if you go for a week somewhere.
It was challenging.
I mean, and that's the thing is it's, uh, I know Dr. Newsom oftentimes asks people, how do you turn it off? What is your thing for you to get away? Because if you can't get away from it, I don't get smarter by being more stressed out with more work
Yeah.
on my back. At some point, you have to be able to unplug. So I think that's part of the staff's reasoning of the way we worded this. We're not trying to say that Dr. Hollingsworth shouldn't practice. We're not saying that, he should have some huge financial penalty for this. It's just, here's what we observed. But at the same time, and I think after, 2 hours we're finally getting to it, that was not an ideal situation to try to have that level of pharmacy practice coming out of a pharmacy.
Now sounds like the perfect time to get trained.
I agree.
If he ever wants to do it again, yeah.
Well, it said he did.
I do. And I do. And I've reached out to some consulting groups that, to name a few, but, some are facility consulting, some are SOP consulting groups. And I will, Advanced 797, where I was getting my, facility validation done every 6 months. He's also a board certified pharmacist, the guy that owns that business. And he's helped me quite a bit on where to get other training, where to get other education. I have not pursued that because I've been very busy with building the framework of a new non-sterile compounding lab, hazardous and non-hazardous, and I want to really build a strong framework there. So I've been swamped with that and trying to focus very hard to cover these bases and apply these same issues, right, with my non-sterile side. And so, but there are a lot of other opportunities out there for training that I didn't even know existed that I'm look forward to working on in the future. I just kind of waiting to see how this planned out before I spend a lot of time and money on that. Because
And in addition to your sterile training and just things that you may need to focus in particular areas on, I would encourage you to just sort of develop a global attitude toward completing the communication loop, which includes documentation.
writing, yeah,
That if you think, all right, I need to complete the communication loop, whether it's with an inspector or a patient or whoever it might be, that inherent in that process, that in completing the communication loop, that's either going to be verbal or written. And that automatically gets you in the mindset of thinking document, document, document. Because it sounds like there were a lot of things that you addressed that you said, I've done, but I didn't document it. And so then therefore I got dinged in this regard. So that's going to be outside of sterile compounding.
nothing against the board in this matter. I just, in my mind, I was expecting something, back and forth relationship with, it just, that's something that I assumed. And again, that's a dangerous word. And so, I know where to get feedback, where to expect feedback from and where not to expect feedback from. And that's something that I've unfortunately had to learn the hard way here.
But you've had a lot of feedback.
I have.
Just not, and that's.
There was communication back and
Yeah.
forth, but when it comes to a red X on something that I needed to see, that's something I need to look elsewhere for, and that's on me.
Well, this is not a board opinion, just a personal opinion. Clearly you've got a knowledge base. There may be holes, there may be areas you need to improve, but you've got a knowledge base to build on. I would encourage you to do that.
Thank you.
That's not a board opinion, that's just a personal opinion.
Other comments from anyone? So what do we want to do here? Not working in sterile right now. But you are working.
I'll float this out there. No sterile compound. If he wants to do sterile compounding, stand up a sterile compounding operation, it's got to come before the board for approval. And $500 investigative cost.
That sounds good. Any other comments?
It'd be non-disciplinary.
Yes.
What's the process for going through that to set back up, start doing sterile again? I mean, we're gonna go in and inspect it anyways, right?
Well, I'd say there's two scenarios. One is if he decided he wanted to go to work for someone that was already an established sterile compounder, then it would be, if you do this, and what you're asking for him to do is agree to it. So it's not an order of the board, it's an agreement. So if he was to do that, he would basically request to come before the board and come explain to, it could be informal committee, here's the situation I'm looking at walking into. Scenario two is if he was wanting to start it from scratch somewhere else, then it would be coming to the board and saying, here's also what I'm wanting to get into. And then it's the board deciding whether or not they would lift that agreement. It's almost like an MOU or something as part of the agreement. So the example I can give is anytime we have someone that goes through the support group, they cannot be a PIC again unless at some point the board approves them to be a PIC. They can't work more than X number of hours without approval. So it'd be very much like that process, which you guys all have experience in.
So, which Dr. Dollar just said, come back before the board before he engages in that practice, that would cover both scenarios.
Yes, yes.
Is there any guidance that we can give to say, hey, if you went and, because, you know, he's looking at spending a considerable amount of money, employer or future employer spending considerable amount of money to send him to some kind of training. Is there something that we can say to say, hey, this would satisfy the board instead of just an open-ended, no, come back in, you know, a certain amount of time and say, are we asking for more training or is it just a?
Yeah, I mean, I
different-
think that would be part of it. Yeah, go ahead, sorry.
I was just saying a different, you know, saying that if we're just starting from a new scratch and that may be enough, I just don't want to say, go out there and do something and then come back and it could be 3 different people sitting here when that happens and it's not enough at that point after they've spent a bunch of money to go through that.
Well, I mean, I think that, you know, the two scenarios I gave would give some clarity to that because there's probably a different level of training we would expect if you were going to try to start from scratch and be in charge of everything versus if you were going into a facility that we already had a track record with of what their inspections were, what their findings were. If you went into a facility that had successful inspections and didn't have red flags or anything else. And I deal this is another great example for support group. You know, if you're under monitoring for us and you want to go take a new job, they will call or email me and say, hey, I'm looking at working at such and such. And there are some stores where I go, there are issues there that would not be an approvable spot for you at this time. Because I know there's either some controlled substance issue or some investigative issue going on in that store. And we would not put someone in that situation if they were, you know, already being monitored by the support group. Like if I know I've got a store that keeps having losses and reporting them and we can't figure out who's stealing drugs in it, you probably don't want to send someone on probation or in that type of a situation into it. But to your point, it's, you know, there are some courses. I mean, I don't know if they're still doing that with that group or not.
I mean, there's still courses, but again, that would go, come to the point of well, how complex is it? If you're doing sterile to sterile, there's a lot. And you start getting where you're not doing sterile to sterile, where it's non-sterile sterile, it gets narrower, a lot narrower. And some that are bigger and sometimes I think it's about perspective too. There's places that are set up really for 503Bs. And for somebody who's making powders, it would be good for them to go because it kind of gives, and like all the stuff that I went through, it's not like I go and inspect manufacturers, but that perspective that I gained from all that training that I did, it lends itself to some decent conversation sometimes. So to get to what you're asking is, yeah, there's some training, but it depends on the complexity of the operation that you're going to walk into.
And maybe it would be fair just to give some general guidance. This is a robust sterile training program that's within the scope of whatever operations he's going to do. We don't have any way to predict whether that would be sterile to sterile or non-sterile to sterile, but you would know as you were going through potentially standing something like that up, what that would be. I mean,
Yeah, I agree.
you're gonna know what-
Building an SOP manual versus going into somewhere that has an SOP manual is months of work difference.
or whether you're going to be focused on sterile to sterile or non-sterile to sterile, or I should say, whether non-sterile to sterile is going to be a component of that program. you're probably going to determine that. So if there's no standardized training program, could we just say a robust, sterile training competency program from a vendor that specializes in these type of,
I think that's your guidance to him. I don't think you would put that in the agreement
right?
because if,
Well, that's what I'm asking. Is
Yeah.
that fair enough guidance to give?
I would think so, because if he comes back in 6 months, that's one thing, but in, this time next year, there may be some brand new thing none of us have heard of that is available that's really good. Was that a motion, Dr. Jolly?
Yeah, I'll go ahead.
I mean, I think my original motion, I don't think I need to modify it unless I'm missing something.
I have it just for our records as non-disciplinary, $500 of investigative costs, and then an agreement to not do any sterile compounding unless approved by the board.
Okay, do I give a second to that motion? Okay, we have a motion on the floor and a second. Any further discussion? All in favor of the motion signify by saying aye. Any nays? Motion passes. Dr. Hollingsworth, we've had a very good conversation this morning. And what we just did, that's our suggestion to you. It's up to you to decide what you're gonna do with that.
I'll take it.
And we will reduce it to writing as part of like a consent order or consent agreement is the way we'll do it, so that the other thing, anybody can go watch this on YouTube. But if anybody ever asks you about it, it's like, this is the document I signed with the board. And that way, if you have any clarification questions on it, we'll be able to talk to you about it. That's it for.
It's
Yes, you did.
non-disciplinary, so it's not reportable to any.
Yep. Thank you for coming in, ma'am.
Thank you. Good luck.
Thank you.
I think we told your boss you had the rest of the day off or something.
You'll take me to lunch.
Okay,
I
comfort
bet you
break?
guys
I don't think I
want
wanna
comfort
eat
break.
anything.
So we'll come back shortly. We've got the pharmacy. Yep. So we're going to go back on for our meeting. It's about 11:25. So Holly, if you want to tell us who you are, and I'll tell you who you're talking to and about this procedure a little bit.
Okay, Holly Hodges with Smith Caldwell Drug.
And as the board already knows, Smith Caldwell no longer exists as a permit. This is about old issues. I'm John Kirtley. I'm the director of the board. On this side of the table, myself, Dr. Brendan McCready, who is our assistant director, and then Miss Ashley Vales, who is our legal counsel. We're all employees full-time here at the Board of Pharmacy offices. The other side of the table, we have 4 of our pharmacy board members, Dr. Clint Boone, Dr. Brian Jolly, who's our board president, Dr. Rodney Richmond, and Dr. Lenore Newsom. Dr. Newsom serves as the chair of our informal committee. In this issue, it's a little bit different than a lot of things we see. Oftentimes in informals, we're dealing with applicants or there have been med errors or something like that. But in this one, it's about old inspection findings from before when the store had closed. We just actually had a meeting with the compounding pharmacist who'd been there at the time and have reached an agreement with him. But the most important thing is we'll give a brief overview. The board has already heard about the inspection stuff, and I think the board wants to talk to you about, your role as the permit holder and the owner. And at some point, they're going to make some decision if they would want to suggest some type of action or what they want to do. Most important thing for you is whatever they come up with, you don't have to agree or disagree with it. Like right now, sitting here is something that we would reduce to writing and be able to send to you. And if you agree with it, then we go forth with whatever it is they've suggested. If you disagree with it, then it would be your chance to say instead, you would prefer to have a full hearing before the board at a later date. We call this informal because I realize it's absolutely formal when you're called before the board, but this is more of a discussion back and forth across the table that's much more open than a formal hearing where we have a hearing officer and a court reporter and we swear everybody in and we have to go very much in a rigid order, much like going to court.
Understood.
I always ask 2 questions. Do you know why you're here today? Do you have any questions about the procedure or how this works?
I don't think so.
At any point during this, realizing you've never sat in that chair and we do this all the time, if you've got any questions, needing clarification, wave your hands, get our attention, ask any questions you want. We'll be happy to try to help answer any questions that you have.
I appreciate that.
Okay. So I think, I don't know, maybe I'll kick this one off. So the board members have already seen the different inspection findings and repeat inspection findings that were namely on the sterile preparation side of what was Smith Caldwell. And anytime we have findings on inspections, and the way that I kind of define this is you could have a single issue or a single set of issues the first time we ever see it that could cause a pharmacy and their pharmacist to be called in front of the board. But oftentimes when it's the first time we see an issue, we try to work through warning notices and education and we help educate and fix it. Other times you have repeated issues, which we had some repeated issues on the sterile side with this. And the fact that you have issues that were repeated that were not fully fixed wind up bringing you in front of the board, which is in many ways kind of the situation we're in today. Regardless of that, you wind up here. The board members have seen and have talked to Dr. Hollingsworth about, how he was the main compounder in there. Talked about, the volume of compounding that was happening both in the sterile and non-sterile side, the staffing of that, and just the overall approach of, what was happening there. I think with that, the board members probably have some questions just of you as the permit holder because you were ultimately responsible for the overall permit in that realm to see what discussion they have with you.
So this was described as a hybrid pharmacy, basically a community pharmacy doing 503A compound.
Yes, it was a very busy community pharmacy. I want to say they were filling 1,400 prescriptions a day, something like that, 1,000 a day.
800 or less
Okay. 800 just on the retail side, or was that including okay.
total.
For some reason, I thought it was 800 retail and then several more with the long-term care side and with the compounding.
So the pharmacy closed, the whole.
It closed and sold different aspects of the business to different entities. So all the retail business went to like local Walgreens, and then the compounding went to other stores that did compounding.
So we're just.
Yes, this is not, we did not have issues with the normal commercial side of the retail pharmacy business. We did not have concerns with the products that were going out on the non-sterile side, but kind of as you heard this morning, there was a lot going on in compounding overall between sterile and non-sterile. But the specific issues of the inspection were all on the sterile side. And so, they have documents and stuff on their pads that they just got to see this morning. So although all of our staff has had, weeks to read this, they have not.
Okay.
So in terms of respondents, basically it's Dr. Hodgson, because the pharmacy is no longer in it.
Yeah, she was the owner of the permit as it existed. So in the order notice, we put it as Smith Caldwell with her as the owner.
Were you doing any compounding?
No, sir, I'm not a pharmacist.
You're not?
I'm not. He was the only compounder. We had a backup if he left for vacation that was trained also, but he was the sole.
How long did you own the store? How long did you own it before it closed down?
I have been employed there since 92. I bought in 2007 and I finished buying in 2020.
So in 2020, you became the full owner?
Yes, sir.
So there were a couple of inspections that were presented in our last session. I think one from 2017, one from 2020, and one from 2023. Specifically for the one from 2023, there were some repeat findings from previous inspections, 2020 and 2017. So as the store owner, what role did you play, I guess, as the permit holder? What role did you play in making sure that all of those things were addressed, either based on the current inspection or repeat findings from previous inspections? For all of those, I guess you were at least a part owner for all three of those, right?
Yes, sir.
Okay.
So, anytime that we had an inspection, we would immediately go over the findings, address those findings as we could, and then get back with the inspector to make sure that that was, okay, that we had done that satisfactorily. And, then we'd move on to the next inspection. I know there's a lot of time that elapses between 2017, 2020, 2023. We felt like that we had addressed these issues, and I don't know if it's the matter of time that elapses and these issues reoccur. Trent always answered the questions, got back with the inspector. Sometimes they were not replied to. And at that point, he felt like that they had been resolved, because at no point would we have been told not to, and we were never told not to do anything, but at no point would we have carried on had we thought that they weren't addressed. And that's why I guess I'm shocked that we're here today. Again, I don't know if it's because, we addressed that in 2017 and then 2020 rolls around and these same issues occur, or if they, weren't addressed satisfactorily and we weren't, on the same page as you guys were.
So as the permit holder, how were you determining that things had been complete? Were you just getting a report out that, hey, this is done? Or would you get more down into the weeds and say, have we addressed this? What have we done? How involved did you make yourself?
Both.
Okay.
Both. So, I would always go over the reply from the inspector with Trent, and then we would go back and forth on what we could do better. And we've gone as far as to do complete remodels without being asked to multiple times to make sure that we were up to par or above. We always tried to be above par. But if we rely on you and we rely on, third parties to come in and inspect us, and we're going with what they say because that's what they do for a living and what you guys say. So we felt like everything had been addressed over time. Of course, the last inspection was days before we closed. So, he's in the middle of getting those answers prepared and getting those back to you all. And you weren't aware that we were closing at that point because I couldn't divulge that information. But, the last inspection, to be fair, we wouldn't have time to address anything at that point with the narrow window. But I'm speaking of 2017 and 2020.
Okay, thank you.
Are you currently a pharmacy owner somewhere else?
No. We had two pharmacies. I moved our LTC into the main pharmacy 2 years ago and then closed the main pharmacy, sold to Walgreens last year in August.
Holly's a pharmacy technician. She's been registered for many years.
I am at Walgreens. No, sir.
Where's the store located? It's here in Little Rock?
Benton.
Benton, okay. Anybody else have any comments?
Not for Ms. Hodges.
Did board staff have a request on this one?
No, it's, part of this is, as you heard in the last thing, it would appear to many of us that the amount of compounding that was going on there was a whole lot of work for, potentially one person or one pharmacist to have been doing that. Anytime that we have, just like when we do with med errors or anything else, we look at both the humans and the business side of it. I mean, of course, Holly's the human in front of us that owned the business back when it existed. So generally we talk about responsibility or corresponding responsibility and where it may or may not lay. You guys may have questions for her about, staffing or how they made those decisions, or if it needed more staffing, if it had plenty of staffing. And it seems like in the earlier stuff this morning, that's probably way more than I would be willing to say grace over as a standalone pharmacist.
How many pharmacists did you have employed?
In compounding, we had Trent was the sole. He had Chad Tarver as a backup, and he had Andrea as a potential backup. She was being trained at that point. He didn't have a budget as far as if he needed someone to help him, it was there. Now in the retail, we're right beside each other in the same building. We had, I believe 5 at the time out front, and at no point could he not ask for help, or, and he wasn't asked to help in retail unless he had spare time ever. I felt like he had quite a bit of time on his hands back there to study and do things other than the sterile compounding. He had a technician, but not for sterile. She was just for the non-sterile part, solely dedicated to him. He was there 4 days a week, from probably 7:30 in the morning until 6 PM at night. Always took a lunch hour. I mean, I've been there since 1992, and at no point did I ever look at him and think that he was overwhelmed with work. Now, he does have a personality that he gets overwhelmed with things, not just work, just things. So I can see him as a person, what Dr. Kirtley is saying. I can see him as a person, thinking that this is a lot to have for one person, but at no point did he ask for help.
You said that if he needed help, there were people that could jump in and help.
Yes.
How many of those people were certified to work in the sterile compounding area? How many had been through the training, the testing, media fills?
Dr. Chad Tarver would be the one complete backup. Andrea was in the process of that in case, for instance, something happened with Chad and he wasn't available when Trent needed him. But at any point when Trent needed Chad, he would call him from out front, which was very, very few and far between, or if he was on vacation or just needed a day off, that kind of thing. And then Chad filled in on Fridays, which was Trent's sole day off of the week.
So you said there were plenty of us out there that could jump in, but there really was only Chad that could jump in at this point.
I guess when I should clarify that if someone needed help on the non-sterile, if he needed help with non-sterile verifying prescriptions, that kind of thing, pharmacists were available for that.
And I think most of the issues fall in the sterile area. So that's why
Yes,
I'm
ma'am.
asking.
I should have
know,
clarified that.
Yeah. So Chad really was the only person that was until
Yes,
Andrea,
ma'am.
and she really wasn't ready because she was training.
Correct.
So he was the only one. And was he there 5 days a week?
He was there 4 to 5, depending on, he generally was there 4. We did the schedules where they did 4 10-hour days for the most part.
Did he work out front by himself ever? Just the 2 pharmacists, one in the sterile, one out front, where he couldn't come back? Was
No.
Chad ever alone out front, so he couldn't come back?
The only time that Chad would be alone out front would have been when we worked on the weekends. There was one pharmacist on Saturday. We used to be open Saturday and Sunday, and during COVID, we closed on Sundays. So Saturday would be the only day, and on that day, there was no compounding being done. That would only be if a person was to be picking something up and needed counseling. But no, ma'am.
So if Chad worked a Saturday, how many Saturdays a month did he work?
They would work one Saturday a month. Sometimes, let me back up. 1 out of 5 would be the ratio.
Okay.
1 out of 5
Still
Saturdays.
compounding on weekends though.
The only time that anything would ever be done on the weekend would be if Trent was called in for an emergency.
Okay.
Occasionally a doctor would, have something that needed to be done and he would come in. I think one time that Chad came in on a weekend and, we would document that on their time cards that, that there was an emergency. I think Trent was out of town.
Well, none of the technicians were trained in cleaning to help clean the sterile compounding suite, or Trent basically did
He did
all of the cleaning,
yes.
all of the compounding.
by his
everything.
choice.
And when you say by his choice, what do you mean by his choice?
He wanted to make sure that was done 110%. And he didn't feel like that anyone could do that but him.
So as an owner, you have all these repeat observations that many of them involve cleaning, sterility, that type of thing. So you have a compounder telling you that he's the one that's going to handle it. He knows how to do it. Yet you have 9 repeat observations. What actions did you take to remedy that?
Well, we felt like that we had addressed those over and over. And like I said, 3 years between inspections. I'm not sure why those were coming back up because anytime that we had our third party people come in to do testing and look at the equipment and check everything, we were even told by the company Advanced 797, they had never seen numbers this low. And he didn't know what we were doing, but we were doing it right. So I'm not sure, that's why I'm shocked that this is coming up.
And did you pay them? They came in and you paid them per job they did?
Yes, ma'am.
Come in and did.
Yes, ma'am.
Dr. Robertson, did you have something you wanted to add?
I just want to clarify something that related to, because the repeat findings and everything like that. Earlier, we talked about how does the FDA do things? The FDA, when they come in and cite you on things, and sometimes they're 483s. If you look at their 483, it might be 18 pages long, and they may spend 2 weeks there. They don't come back and give you a plan of action. You have to come up with your own plan of action. I don't live, we show up I have 140 other licenses to inspect. So you have to understand the logistics and the reality of how inspections occur. So I think that's something that just needs to be kept in mind.
It's kind of a picture in time, just
Yep.
right there. It's a moment. And it is the licensee, the
Yep.
owner, the pharmacist's responsibility to make sure that they're in compliance.
And there was some stuff that was submitted that said, yeah, we'll fix it. And when you come back, they weren't. The things that said were going to be done weren't done. So.
Thank you.
Have any comments? Or what is the will?
Based on the notice of hearing, the charges seem a bit nonsensical to me. Written nonsensical, I'm just saying that I can't make, it says if proven true that the respondent be ineligible for sterile compounding products, but they're not a pharmacist, so they couldn't do that anyway, and the pharmacy doesn't exist anymore, so that respondent's not responding to anything. So what are we being asked? What's the?
I was thinking, well, go ahead, Dr. Curley, you will say something.
Go ahead.
Well, I would interpret that more, maybe if Ms. Hodges were ever to become an owner in a store that was going to do sterile compounding, rather than actually being the compounder.
Yeah, or to operate one. I mean, the allegations speak to, she's not a pharmacy owner now. She's owned 2 different permits in the past. Once again, our concern was namely with the sterile side. It's something that it's not an issue of current. It's a guard against the future, basically.
Charges seem to be one and the same. I mean,
They are. I mean, we basically mirrored what we did for the pharmacist because they share responsibility it's real easy when it's a pharmacist that's doing the activity and owns the store. Where it gets wonky is when it's not a pharmacist that owns the store, or if it's a pharmacist that isn't the one that's actually doing that practice.
well, to me, it makes it a little more clarifying because then the pharmacist who's doing is also the one that needs to ensure to do.
Yep.
So I would treat this the same way we did the other one.
Just the same, maybe consider extending the same.
Yeah.
Thing as what we did in our previous.
I think it'd be appropriate.
That's all.
I guess the caveat would be
If she wants
or
to,
if she wants to operate, partially own
yeah,
the pharmacy.
if she wants to be
that's
involved,
Gonna do sterile compounding.
yeah, if she wants to be involved in ownership of a pharmacy that does sterile compounding. In Hollywood, what they're talking about is what they extended to Trent was a non-disciplinary agreement that if he wants to get back at some point into doing sterile compounding, he would have to come back before the board for approval to be involved in sterile compounding. And then they assessed a non-disciplinary fee of investigative cost, a minimal one at like $500. So it was basically helping to reimburse the board for part of the time and effort of having to go through the case itself.
Understood. Well, he may want to get back into that, but I'm retired.
Yeah, I understand. Yeah, and so it does nothing to you. It's just if you at some point, we've had people retire before and someone go, we've got this amazing opportunity where you can invest. It's one of those never say never things. And you go, if I'm going to do it and it's got sterile, I'm going to have to go visit with the board. So
Insurance companies have made that impossible, so.
I understand.
You're still a licensed technician,
I am, yes, sir.
active permit through the state?
Yes, sir.
And you may say she can't do active, like sterile compounding as part of it.
I was gonna say
Is where
we
you're
need to
going.
include that part of it.
So Dr. Shaw, is that or Dr. Richmond, is that a motion to basically mirror what we did earlier along those guidelines and add that she can't do sterile
Part of it
compounding?
would be you can't own or have any partial ownership in a company that does sterile compounding or participate in sterile compounding as a technician.
I don't know about the second part. She decided to go work for a hospital. I don't know that would necessarily have a problem with her compound. I don't think she's here because her compounding technique was bad or she participated in any compounding activities. Yes, she was the permit holder. But if you want to make that a motion, I mean, I'm not necessarily opposed to it. I'm saying.
Well, I mean, the fix would be easy if she came back and said, I'm gonna do sterile compounding in hospital. Okay, that's fine.
Yeah.
I can't own a pharmacy again by my contract for 5 years anyhow, which I'm not going to anyway, but I don't know if I need to say that or not.
Look young enough for 5 years, probably won't make it.
I wish I were, but I'm not.
Okay, so the motion would be,
Non-disciplinary,
non-disciplinary $500 investigation cost.
cannot participate in or own a pharmacy doing sterile compounding
Unless they come and meet.
without approval.
Without approval from the board. What was there a third part to that about?
No.
Working for an employer that's
Think participate kind of.
Okay.
Okay, got a motion and a second? Got a second that?
I'll second.
Have a motion and a second. Any further discussion? All in favor of the motion signify by saying aye.
Aye.
All right.
Any nays? The motion passes. You understand,
Yes, ma'am.
Captain? Okay.
So Holly, we'll put it in writing and send it to you. That way, if you've got any questions about it, it'll be a consent agreement.
Okay.
Since they've determined that it is non-disciplinary, it will not be reported to the National Practitioner Data Bank or anything else. It's not a disciplinary mark on your license
Understood.
individually.
Appreciate that.
All right.
Sure.
Thank you for coming in.
Thank you.
Thank you.
Thanks.
Next up, you guys should have Mike Murray, who I've got to get back in my documents to pull up.
Thank you.
I don't know if I've got Mike Murray in here.
It is.
There it is. Okay. Let's look at all. There he is. Got him. Where to look?
You want to introduce yourself? I'm going to tell you who all you're talking to and a couple things about this procedure.
Mike Murray.
Okay. And Mike, you're a pharmacist here in Arkansas.
Yes, sir.
How long you been licensed now? You can tell me what year. You don't have to tell me how many.
78, I guess.
Okay, that was a good year. So I'm John Kirtley. I'm the director of the Board of Pharmacy, and up at this table, just, you're talking to myself. Dr. Brenda McCready is our assistant director here at the board office, and Miss Ashley Vales is our legal counsel. We're all three employees here at the Board of Pharmacy office. The other four people you're talking to today, Dr. Clint Boone, Dr. Brian Jolly, who's our board president, Dr. Rodney Richmond, and Dr. Lenore Newsom. Dr. Newsom's the chair of this informal committee. You'd received an order notice of hearing. We're here today to talk about there was an unfortunate event in the pharmacy, a med error. And in this, what I usually do is I kick it over to our staff to just give a brief overview of what happened. And then generally the board members want to talk to you about that situation. We call this informal because we're having a conversation back and forth across the table. I realize anytime you call before the board, it's going to feel really formal no matter what. But this is a less formal thing than a full hearing. At some point, they're going to come up with some suggestion of how they want to handle this situation. And the most important thing is you can choose to agree or disagree with whatever they suggest. And you don't have to do it sitting there right here today. Whatever they suggest, we're happy to put into writing and send it to you. That way, if you have any questions about it, any clarifications, then we will give that to you. And you can, if you agree with it, we go forth with whatever they've suggested. If you disagree, it's your chance to appeal what they've said and have a hearing before the full board, which is 8 members. We'd have a hearing officer and a court reporter, and we swear everybody in, and it's just a more formal procedure. But I always ask, do you understand why you're here today?
Yes, sir.
You have any questions about how this works? At any point during this, realizing you don't sit in that chair all day like we have to sit up here and do this, if you have any questions that you want something clarified, by all means, please ask us. We want to help answer any questions that you have. Okay? Ms. Vales?
So you have an order notice and hearing in front of you for guidance. This came in as a complaint from on May 11th, 2023, a patient that we'll refer to as SF came in to Economy Drug where Dr. Murray was the pharmacist. SF complained of congestion and Dr. Murray counseled SF. They decided that guaifenesin would be the appropriate medication for her symptoms, and he advised her to take 12 pills in a day to clear the congestion. Dr. Murray stored those tablets, the guaifenesin, behind the counter with the prescription medications on the same shelf. In your packet, you have a picture of that our investigator took. And Dr. Murray admits that he reached over a partial bottle of guaifenesin to get the full bottle, and in doing so, he mistakenly pulled out a bottle of glipizide. Without looking at the bottle, he placed the bottle in the bag for SF. And SF took 4 pills that afternoon and 4 additional pills that evening, as she was advised to do. We should note that SF is legally blind, and Dr. Murray was aware of that. Because she ingested the wrong medication on May 12th, the next day she was admitted into the ICU due to the ingestion of glipizide.
It was a glipizide ER 10, I believe.
Okay, how's this patient doing now? Heard anything on her?
No, I have not. I've called, but was not answered.
Have you had any contact with her? No.
What finishing product do you recommend?
The 200 milligram guaifenesin immediate release tablet.
There's a picture of it at the very end of the document, but you have to shrink the picture down to actually see it. It's a large. It's just the regular 200 milligram immediate release in just a bulk bottle. It does not appear to have the RX legend on it. I've seen, some pharmacies will only carry it in small bottles. Some will carry it in larger bottles or quantities that they can get like that.
Okay, you still practice in pharmacy?
Yes, ma'am.
Okay, so, what changes have you made to your, practice to, stop anything like this from happening?
Well, we removed all the over-the-counter items from being intermingled with prescription items. It's just myself at the pharmacy, and rather than go out front, we had them in the back. But rather than intermingled, we've set separate shelves with a label on the shelf that says over the counter, separate from the legend items.
Do you have a point of sale system to scan out items when you're
No,
billing
sir.
patients?
No.
Have you made any type of restitution, like a hospital bill or anything like that?
I would be more than happy to. I've known these folks for many, many years. And, I wish very much they had allowed me to talk to them, or that we could have done something for them. I really would love to do something for them. Haven't communicated with me at all. No, the whole family, we've interacted on other than this pharmacy where we were pretty close, I thought. So. Whatever they want.
What is that shelf in front of the,
Is that part of your dispensing counter that just butts up to the shelf, or like another counter that butts up that piece of wood?
Piece of wood is mainly where we set orders and check in the orders and
But
whatnot.
it's a table or something just adjacent to the shelf.
Yeah, it's a piece of wood, and then there's another table over here.
So now you've got like a section of your shelf behind the counter that just has OTCs you would grab to help
Yes.
serve patients. And you don't, I don't think I have been in your store actually, but you don't have like a big OTC section out front, do you?
It's shrunk over the years. It's
Yeah. You've got some other gifts, I imagine, or
mainly we just have exhibits of old stuff. So
Yeah. you got a museum.
mainly.
Anyone else have any questions or comments?
You said you don't have a technician or anybody working with you. It's just you at the store.
Are there any changes you've made to the setup in term, and maybe somebody asked that question while I was reading, but is there, if you've commingled prescription product with over-the-counter product and you just reach and grab it, particularly if you're not gonna bother to look at the label and read it, I mean, what changes have you made? I mean, have you segregated them? Have you moved them?
I have moved them. And I was very remiss on that. There's no excuse for it, of course, but as I reached for the thing and I knew Craig, and I'm sorry, I shouldn't say names, but I knew them quite well. He was talking to me and I turned my head back when I reached for it and answered his question, and then failed to look at it, verify it. It's completely my error.
Well, and thanks for acknowledging that. And I didn't mean for that to come across maybe as quite as sharp as it sounded now that I think about it. But I guess my main point is if you're going to commingle over-the-counter product with prescription product, you run the risk of something like this. And I don't know what the age of this gentleman was, but if he was elderly, that puts an even greater risk. Certainly extended release makes it's gonna last, that effects will last even longer. So
They're on a shelf that I would not normally have anything now. It's inconvenient for me to reach all the way to the floor. So I moved them down to the floor where I have to actually get down and,
And that's not just for this product, but
no,
that's for over-the-counter products or anything like that in general that needs segregated.
yes, sir.
Have you done any continuing education on how to physical barriers or things that you can do that will help minimize errors?
I don't recall doing any of this time, no.
Well, this is a very specific type of error, but there are lots of different things that redundant systems, barriers that force you to do things a certain way, like you've done by moving it to the bottom shelf. That makes you be purposeful. You're not just gonna reach down there. Of course, if you reach down there, you still gotta make sure you read it.
Yes.
But I mean, I would encourage you to, perhaps even as part of this, that we have you do some continuing education to seek out things that will help to prevent medication errors. And there are, ISMP is a good place to find some information about things like that.
Where's that?
Institute for Safe Medication Practices.
So what is the will of the board?
Do we have any type of precedent for a med error causes patient harm?
Well, this one's weird because we generally are seeing, if this was the wrong drug of a prescription behind the counter, then we would look at, was it new or was it a refill? Was counseling required? But this was, intent to hand someone an OTC item that happened to be behind the counter and accidentally gave them a prescription drug. If it was the minimalist approach that we have looked at in the past, if it was a prescription drug and the counseling was not of issue, but there was an error with harm, usually look for a block of CE and then a minimal investigative cost. I don't know. I hadn't had this before.
Well, I think counseling becomes inherent in this because he by definition recommended the product.
Yeah.
And was handing it. So counseling would be required as part of that.
Yeah, which happened. Arguably, it was just then the wrong product was handed.
And the bottles are similar. I mean, a white bottle with the little groovy top.
All the more reason to make
Yeah,
sure.
you look at it, yeah.
I mean, he's admitted he
Yeah,
failed to read
yeah.
the label.
I mean, in something like this, we have a few pharmacies that will hold some of the OTC stuff like that behind the counter just because it's, easier to get to or because they specifically recommend it for patients. This one just is the train wreck that got you that day.
Yeah.
Well, this would seem to be similar and akin to something we heard earlier, but
Yeah.
the only difference is there's patient injury. I mean, in a just culture, it would be a non-disciplinary.
Yeah.
I look at what I said, what DB says we do. Look at what lines on when we were.
It's up to the board to determine which approach you
It is.
want in it, but you're correct. In a just culture approach, this type of an error would generally be non-disciplinary.
Well, from my way of looking at things, I always ask for action plan. Something has been done. Suppose that would be sufficient. I would ask for 10 hours of continuing education and medication error prevention. And make it non-disciplinary, but there's any sort of fee that has to be assessed. Is that different because it's patient injured or not? But non-disciplinary, 10 hours of CE, except the action plan that he's.
If it was both prescription drugs, I think usually you'd attach like a $250 investigative cost. I don't say that to beat him up at all. It's just, if it was 2 prescription drugs, that would be fairly normal.
Yeah, but I think since I agree with Dr. Richmond, since he kept it behind the counter, it was his responsibility. You have a patient that's legally blind. And so it's his responsibility to look at it and make sure he's giving her the right thing. So I think there's some culpability there that, yesterday we had a glipizide error and it kind of went this way. This is all linear. This is just, and so I don't really see that there's a lot of difference in what you find yesterday versus what you would find today.
$250 investigation.
That was what we did.
Mhm.
Have you put that in motion? Adding the $250? Yes. Okay, I'll second.
Have a motion and a second. Any further discussion? If not, all those in favor of the motion signify by saying aye.
Aye.
Are there any nays? The motion passes.
Dr. Murray, what they're proposing, and we'll put it in writing for you, is they're going to ask you to get an extra 10 hours of CE and to have some of that focused on like med error reduction, which is a topic that we see a lot of CE on. And then asking you to basically reimburse the board $250 for the cost of actually investigating this issue. They're saying it's non-disciplinary, which means your license will continue to have no under disciplinary action because they don't think it was, to the level of being egregious for disciplinary action. And it will not be reported to like the National Data Bank to flag you, which would affect contracts or anything like that. So we'll
Make sure you also understand that 10 hours are outside of the 30 hours of biannual.
extra.
So in other words, you would need to get 40 hours of CE in your 2-year period.
We will put that in writing and send it to you. Do you have any questions about that or clarification? Okay. This is one of those things could happen to any of us. It's just,
I just want to say how sorry I am, and this will haunt me forever.
well, it's one of those, as humans, if we all practice long enough, something's going to happen sooner or later. And thank goodness they're okay from it in the end. And, you learn from it and you move forward. Thank you for coming in.
Thank you.
Absolutely. Guys, that's all I have before 1 o'clock. Do you guys want to come back at 1? Or you want to try to say 1:15?
Depends on how quickly we can.
Yeah, you'll say 1:15 just in case. Okay, we'll plan to be back at 1:15. If we get back a few minutes early, that's just bonus.
Economy drug.
Okay. All right.